Topic which I'm going to discuss is about the iron nail penetration injury and its management. Before I was going to prepare this slide, I thought that just let me look over the Google that how many people are actually getting injured by the trauma or any kind of trauma. So it came to my surprise that WHO program prevention of blindness, it suggested that about 55 million eye injuries restricting activities more than one day. About 7,50,000 cases will require hospitalization and 2,000 open globe injuries and approximately 1.6 million blind from injuries. 2.3 million people with bilateral low vision and 19 million with unilateral blindness or low vision. The most common causes of ocular emergencies in India is, according to the NPCBs, trauma, infection, glaucoma and others. So we start with the case. Patient came to our emergency, 35-year male, with the injury from iron nail while working in his shop. History of presenting illness: he was working in a shop with hammer and nail when all of a sudden iron nail slipped and entered in his eyes, which was sudden in onset and gradual progression of pain with sudden diminution of vision. No restriction of movement, no diplopia, no vomiting. In past history, there was no ocular surgery or no infection or trauma. General examination: he was conscious, oriented to time, place and person. Blood pressure, pulse were normal. System examination was normal. Head posture, facial symmetry was normal. Eye alignment was normal. Ocular examination: vision, right eye was 6/60. Left eye was 6/9. As in this image you can see, the cornea, conjunctiva, sclera, antechamber and iris, there is an iron material or iron nail has perforated it. In cornea, the Siedel's test was negative. Pupil was reacting to light, but it was D shape. Lens was normal. Extraocular movement, it was full and free, and fundus was normal. Investigation: we did the B scan. In this, we can see there was no spikes, and so there was no enter in the posterior segment. Pre-operative preparation: we did we gave the injection TT, injection diclofenac, pantoprazole, domperidone, tablet Damox. We advised patient to avoid bending or Valsalva maneuver. Guarded prognosis was explained to the patient and written consent was taken. In the surgical management, carefully a nail was removed. Vitreous loss was there from the wound, so anti-vitrectomy was done. Cornea, limbus and sclera was sutured with the 10-0 nylon, and intracameral moxifloxacin injection plus subconjunctival dexamethasone and gentamicin injection was given. This was the post-surgical image. Medical treatment, which we started with the amoxiclav 625 mg, tab Damox 500 mg, moxifloxacin dexamethasone eye drop every hourly, tab diclofenac, atropine eye drop 3 times, tab Visulon 40 mg and tab rabikind. So this was the image in the first day follow-up with the vision 6/60. In day 4, vision was 6/9. So this is the fundus image and the antechamber image. So the classification of the ocular trauma, various factors are there: local, associated or environmental. The global will go with the structural or pathological. Closed globe, open globe, destructive globe. So there is a classification called Betts classification, which divide closed globe and open globe. Closed globe is contusion and lamellar laceration. Open globe is rupture or laceration. Laceration further divides into penetrating, perforating and intraocular foreign body. Open globe classification has 3 zones: zone 1, 2, 3. Zone 1 is injury in the cornea or limbus. Zone 2 is injury to the anterior 5 mm of sclera, and zone 3 is the full thickness of the injury. According to this case, this is a type of B, penetrating type, and grade will be 2 according to the initial visual before surgery. Zone 1 in the cornea and sclera, and ocular trauma scoring category is category 5. How we give the category 5? We calculate it by the variable and raw points. According to the vision, if it is more than 20/40, the 100 points comes. To categorize and potentially visual outcomes, we need to determine the raw point first, then calculate the sum total of the raw point and convert the raw point into the percentage chances of vision. So according to that, it comes into the 0.5. To my conclusion, according to the BETS and the ocular trauma scoring, type 2 of injury was perforating injury. Grade 2 visual before surgery was 6/60, and after 1 week it was 6/9. And zone of injury is zone 1. And OTS category 5, if the prognosis is good. But we need to still follow up till 3 months at least. Thank you. Ma'am, first the patient was given the prognosis, negative prognosis was been told to the patient. Written consent. Yeah, ma'am, the prognosis can be good also, bad also. So the patient was explained about the situation. After that, the written consent was taken, and then injection TT, diclofenac and domperidone, rabiprazole. So that he should not vomit or he should not do at that time. Tablet Diamox, so the vitreous, if any, so intraocular pressure, we cannot measure the intraocular pressure, so we gave the Diamox also. So this was how we did the pre-operative preparation. Perforating, yes, perforating indeed.
Surgical management?
Surgically it was managed, ma'am.
Surgically.
The nail was removed, and then, sir.
What is the risk of siderosis in this patient?
Sir?
Risk of siderosis.
There is a risk, sir. There is a risk. The end of risk is also there. Iridocyclosis is also there. Sympathetic ophthalmitis is also there. So the risks were explained to the patient.
Yeah. And later part you may get cataract.
Cataract, yes, sir.
Okay, very nice.
Thank you, sir.
You are not tempted to remove it on the OPD itself. Patient also didn't remove it. That's the best thing. Otherwise.
He directly came to us, sir, in half an hour or 1 hour he came.
Sometimes they want to pull it.
Yes, sir.
Or the attendant pulls it. Then you had it.
Okay, thank you, sir.
Our next speaker, Dr. Sushil Pani, sir. Please come to the stage.
Good morning, respected chairman and dear friends. My topic is relatively innocuous in one sense. Most of us did. Most of us are not bothered about it. It is about whether we see glistening of the eye well and whether the glistening is important or not, how to document it, how to classify it. I have no financial interest in any of the products owned. I have not named any of the products. There is a lot of debate over which eye well is glistening happens, which doesn't happen. So, if you observe carefully, you can see the front surface and the back surface of the lens and the wavy pattern of the front surface. The impact, you can see the back surface also wavy pattern. No, does it matter? Should I worry about what we see? Should I look for glistening specifically? Can I grade those into the severity of the glistening? Should I tell the patient it's been operated elsewhere? And what should I do, if at all? Glistening by definition is that formation of microvacuoles on the surface and the body of the lens, which gets filled by the aqueous over a period of time. So most of them say that you don't get the glistening right at the start, and it reaches a peak and doesn't change over time. That is one part. And you have to differentiate glistening from opacification. Okay. Almost all the IOLs we see glistening except PMMA and some of the old silicon lenses. Now, of course, there is a big noise about the new material, so-called new material made by Alcon, the Clarion platform, which they say that there is no glistening. But time only will tell, because this platform is very, very young. So we have to wait till see. Their other platforms are really not that great. So here what you see, the entire IOL is glistening is there, and the posterior part of the lens is almost starting to opacify from the top. So glistening does matter, but not to worry. Most of them say that there is no visual impact on the visual acuity. We have to develop some newer methods to compare the glistening onto the total visual spectrum of the patient. We can do only two of the tests. Measure is contrast sensitivity and the visual acuity. These are the two things we can do. But whether we can develop other parameters to measure along with the glistening. The other thing is, we have to document it by picture, video. The best way to document is newer methods of photography, and OCT. There are exclusive AS OCT only helps. The standard OCT, which is mostly meant for posterior segment, if you attach the anterior segment component, the lens in front, to take the pictures, we get excellent pictures in phakic conditions. In pseudo-phakic conditions, we don't get that great. I tried, I couldn't get the pictures. In two of the machines I tried. But in phakic conditions we get. Of course, slit lamp is gold standard to, and we should not be in a hurry to, because we document, take a picture, we can show the picture to the patient. We should not be in a hurry to tell the patient that something is wrong. Don't do that. What we have to do is check for other things which are important before we say that here is here you can see the front surface, back surface, as well as the back distension is there. So you see a big gap between the posterior capsule and the lens. So there are four things which you need to see. This is the gradation of the glistening, and grade 1, grade 2, grade 3, grade 4, depending on the size of the. So there are three parts of the lens which need to be checked for. One is the front part, anterior surface, posterior surface, and the body of the lens. And along with that, we need to check for the, here you see a nice glistening of the body of the lens, these fine dots which you see along with the anterior capsule and the anterior part of the lens and the posterior part of the lens. Now these are the different types of IOL which has been documented. Almost all the lenses we see with. Do I have another 2 minutes? So there are four parts: the front surface, the body of the lens, then the posterior part of the lens, and the gap between the lens and the PC and the PC itself. All the four need to be differentiated. There are four things which we need to see: whether there is a distension of the bag, whether there is PCO, whether there is only glistening. Never do a YAG for only glistening, because if you are doing YAG, you are damaging the lens, plus you will, if the clear PC is broken, if you have to plan for an exchange, you will have difficulty. These are some of the lenses. This is to differentiate between the lens glistening and PCO. Retroillumination is the best. Even in retroillumination, here is the retroillumination showing the early glistening. Here there is a generalized haze. So you should not do a YAG in these cases because you will end up in more trouble. I will show some videos in the end. See what is the impact of glistening. The surface of the IOL, both front and back, which forms the most important refractive element, there is wavy pattern, irregular surface, reduced contrast, scattering of the light. And if it is severe, then it may progress to fall in visual acuity. Otherwise, the fall in visual acuity is the last. So we should not be in a hurry to try to go for exchange of IOL or anything of that sort. This is a diffuse illumination. It doesn't show much of a glistening. Only the few dots are seen on the front. And all the materials we get glistening except the PMMA. So very common if you can easily document it, but don't worry. Look for causes of other causes for visual disability, what the patient says. And with most of these patients being older age group, you have to look for dry eye, look for ARMD, look for other causes. Then in the last only we think of glistening may be a cause of the symptoms. And you have to differentiate between what I have told already, the PCO opacification, distension of the capsular bag, and glistening of the surface and glistening of the body of the lens. And never criticize your colleague because it has been operated elsewhere. And don't be in a hurry to plan for a IOL exchange. Thank you. No, just hold. Yeah, start. Only if you are very, very sure that the visual acuity has fallen because of the glistening, grade 4, then you plan. It's like if you are a photographer and in the front element of the lens, you see very fine dust which you are not cleaned. Even when you are doing a slit lamp examination, you have to periodically clean the optics. There is a very marginal difference. Unless you really zoom the picture, then only you find the difference between the fine dust on the surface of the lens and the. Otherwise, most of the senior consultants, most of the top people say that it doesn't matter. The company also says it doesn't matter, but it does matter. And pioneering work has been done by Dr. Ramesh Durerajan from Chennai, who has documented extensively this glistening, and he has even pointed it out to the companies. The companies don't agree to that, but that is also a major reason to come out with newer material IOLs. There are two major newer material IOL. One is a hydrophobic hydrophilic combination, hybrid IOLs, which some of the Indian companies have come out few years now in different platforms, monofocal, multifocal and all that. And of course, Alcon has come out with the Clarion. The reason is for this purpose only. Even they will never agree to that, but this is the reason. And hydrophilic lenses have been criticized more because of the PCO and opacification, two things. But they are excellent lenses as far as glistening is concerned, because they are hydrophilic, they are already in the media. Yes. So glistening is relatively very rare. If there is a defect in the production, you get opacification straight away. No defect, its lifetime remains fine. Most of the cases I have diagnosed by my examination. I don't tell the patient you have got glistening 2, 3, 4. I just document it. That is why it's very difficult. Yeah, but before you point it out as because of glistening, you look for other causes. If there are no other cause and the glare symptoms are more, then definitely you think of glistening as the cause, because lens exchange is not a simple procedure in late post-operative phase. See, this happens after few years. So if it is immediate post-operative for some reason, manufacturing defect, one can go ahead quickly. After rule out everything, all other causes, do an OCT macula, do a, find out the refraction, find out any excessive cylinder power, find out all other causes, dry eye, 3 major causes for macular degeneration. For ruling out everything, and patient is very, very much symptomatic, particularly if there is a difference between the two eyes with two different IOLs, and the glistening is more in one particular eye, then definitely you should plan for an exchange IOL.
Sir, just 1 minute, sir. You told that not to inform the patient about the things going on.
Yeah, absolutely.
That's very absolutely correct, sir. But how you would like to manage these patients complaining of glare, especially during the afternoons?
No, for that you have to plan out for external spectacle or with different
Either
grades
whether
of.
you go for that photochromatic glasses or this.
No, there are multiple options. There are multiple options in the glasses. Nowadays you can get what we call as gradation glasses.
So that gradation glasses are for the people who can afford money, sir. I'm telling about the patients who are getting
Yeah,
operated.
if the glare is too much, you can use a B2 glass in the daytime, and you can use a photochromatic is good enough, but that may not be enough. If it is not enough, then go for B2, next level. Or if they are willing to go for the graded, what we call, that is a term for that, where it is graded from top to bottom. Top part is most dark and the lower part is lighter. So they can go for that with prescription. They are expensive, but definitely less risk in comparison to going for exchange IOL.
Yes, and the second thing is these patients complain more
Yes.
when they have a dry eye associated with it.
Yes. That is why you have to take care of
Dry
other.
eye gives you the maximum complaints with the
Yes.
glistening.
Yes. You have to take care of the dry eye. Thank you.
Most of people doesn't complain anything. Only the drivers can complain about the glare. Drivers, they are not able to go for IOL exchange and also not for the graded spectacles.
Our third presenter, Dr. Sahakriti, Neuro-Ophthalmology. Sorry, Sikriti. A very good morning to one and all. So before moving to the topic, I would just like to say during my residency, few of my batchmates said, whoever doesn't want to do emergency duties, please take ophthalmology or ENT. But what we realize that ophthalmology is not far from emergencies. There are so many ophthalmic conditions, and specifically the neuro-ophthalmic conditions, which are emergencies and sometimes urgencies. So, my topic is neuro-ophthalmic emergencies, which is titled From Light to Dark. The objectives would be to describe what are neuro-ophthalmic emergencies, what is the role played by an ophthalmologist, few cases I will be discussing, and how to tackle them. So coming to the introduction, neuro-ophthalmic emergencies constitute either vision or life-threatening conditions if they are not diagnosed and treated properly. They present with certain neuro-ophthalmic signs and symptoms, which includes acute vision loss, transient visual obscuration, diplopia, ophthalmoplegia or ophthalmoparesis, ptosis, headache, loss of the visual field, pupillary abnormalities, which are very important to clinch the diagnosis, and loss of sensations along the course of the involved cranial nerves. This is the list of the various neuro-ophthalmic emergencies and urgencies we come across. Coming to the first case, a 71-year-old male presented to us with sudden painless loss of vision in both eyes, along with the drooping of both eyelids since the last 15 days. He had a severe ptosis with moderate proptosis in the right eye, a 2 mm of lagophthalmus with loss of sensations over the forehead and face, along with loss of the corneal sensations. Right eye had a 5 mm of anisocoria, whereas left eye had mild ptosis. His best corrected visual acuity was PLPR inaccurate in the right eye and 2/60 in the left eye. As we can see here, he had a 45 prism diopter of right exotropia with 14 prism diopter right hypotropia and this motility limitation. And fundus examination, there was bilateral disc edema with 360-degree RNFL edema. We did the neuroimaging, in which we found the hyperintensities in the right orbital apex, which was also progressing to the cavernous sinus and extending to the left orbital apex. MRA was done, which was normal. With this, we came to a provisional diagnosis of bilateral orbital apex syndrome, which could be secondary to any IgG4 related disease or neoplastic origin. The serum IgG4 assay was ordered and the reports are awaited. The patient was urgently referred to the neurosurgeon for further management. Coming to my second case, a 29-year-old male complained of painless sudden loss of vision in the left eye since the last 8 days. He is a known case of sickle cell trait since early childhood. His best corrected visual acuity was 6/6 and 6 in the right eye and counting finger close to face in the left eye. Left eye had a grade 2 RAPD. As we can see here, there was severe narrowing and reduced caliber of the retinal arterioles, and there was this fundus had a pale background with the cherry red spot in the left eye. We did the FFA where there was increased arm to retina time in the left eye of 23 seconds, and there was on the OCT left eye hyperreflective inner retinal layers were seen, which was suggestive of retinal ischemia. With this, we came to a final diagnosis of left eye CRAO secondary to sickle cell trait, and the patient was managed. Coming to my third case, she was a 31-year-old female who complained of sudden onset of loss of vision along with tinnitus, headache and neck pain since 15 days post-delivery. She was a known case of gestational hypertension. Her blood pressure was measured to be 160/100 mm of mercury. The best corrected visual acuity was no perception of light in both the eyes, and there was -3 abduction deficit in both eyes. Pupils were round, regular, fixed and dilated in both the eyes. We can see here there was bilateral disc edema with RNFL edema, splinter hemorrhages, exudates and tortuous vessels in both the eyes. So with this, we ordered neuroimaging, and there were signs of raised intracranial tension and MRI brain and orbit with contrast, along with the stenosis of the left transverse sinus. The patient was immediately referred to the neurologist. They did the CSF opening pressure and analysis, and the CSF opening pressure was very high, but the analysis was normal. So with this, we came to a final diagnosis of both eyes papilledema and fulminant IIH with left CSVT and both eyes 6th cranial nerve palsy as a false localizing sign. The patient was initially managed with bilateral optic nerve sheath fenestration, followed by 3 doses of injection intravenous methylprednisolone, tab diamox and syrup patchlor. But after that also, there was no improvement in the vision in both eyes. For further consultation, we referred the patient to the neurosurgeon for a repeat lumbar puncture and shunt procedures. And the patient was then till continued with injection IVM pen Diamox. After the shunt procedure, when the patient came to us after 2 months, her vision has improved to 3/60 in both the eyes, and there was improvement in the ptosis as well as the motility and other parameters like strabismus. Coming to my fourth case, she was a 62-year-old female who presented with sudden painless decreased vision with inward deviation of the left eye since the last 20 days. She had a history of spontaneous brain hemorrhage 1 year back. We did the dilated fundus examination, which showed the features of impending CRVO. The MRI brain and orbit along with the MR angio was done. As we can see here, there was bilateral prominence of the superior ophthalmic vein, and also this MRA was suggestive of the high flow CCF. The patient was immediately referred to the neurosurgeon for further management. Coming to my last case, a 38 years old female complained with sudden onset severe headache with diminution of vision, drooping of the right eye, abdominal pain, intermittent vomiting, which has worsened since the last 4 and 5 days. On general examination, she had a tachycardia and hypotension. Her best corrected visual acuity was counting finger close to face in the right eye and 1/60 in the left eye. She had a moderate ptosis in the right eye. The Herzberg corneal reflex test showed a 15 degrees of right exotropia, and there was gross motility limitation except abduction. There was 4 millimeter of anisocoria in the right eye. On the fundus examination, we can see there is a florid disc edema with hemorrhages and dilatation and tortuosity of the blood vessels in the right eye, and there is a pallid disc edema with few splinter hemorrhages and 360-degree resolving RNFL edema in the left eye. We did the laboratory investigations, which was suggestive of a hyponatremia, and hormonal assays showed deficiency of the ACTH hormone. We then proceeded with the neuroimaging, which was suggestive of a pituitary macroadenoma with pituitary apoplexy. MRA with contrast was normal, so the patient was managed with urgent neurosurgery referral and endocrinology referral for hormone replacement therapy. Then coming to the surgical third nerve, which is seen in 9 to 36% of all the third cranial nerve palsy, the most common cause being intracranial aneurysms, mostly of the posterior communicating artery. There is a high risk of aneurysmal rupture with increasing age, smoking, female sex, hypertension, alcoholism, patients who have an aneurysm size more than equal to 10 millimeter, location of the aneurysm in the posterior cerebral artery or the basilar tip, those with positive family history of subarachnoid hemorrhage of intraocular hemorrhage. As we always know, digital subtraction angiography is the gold standard for diagnosis, and the patient can be managed by urgent referral to the neurosurgeon via the surgical or endovascular approach. So what is the role of an ophthalmologist? We should take a proper history of the patients, both ocular as well as systemic. We should do the detailed ocular examination. We should have a prompt systemic evaluation and referral to the concerned specialist, ordered appropriate investigations and interpret them correctly in conjunction with our colleagues in other departments wherever needed, and early and appropriate diagnosis has to be done so as to manage the patients properly. These are the general examination which we should look for. Then this is the list of the ocular examination which we should do. Ocular investigations have to be done in certain cases like visual field testing, OCT, FFA. Then laboratory investigations wherever needed. In the radiological investigations, MRI with MRV is important. In certain cases like GCA, we should go for the carotid Doppler, and MR angio is important to rule out any aneurysms. Other investigations like CSF opening pressure and analysis has to be done if we suspect a raised intracranial tension. So the take clinic message is, a detailed and systematic examination is of utmost importance when approaching a patient heralding any neuro-ophthalmic emergency. The examination of a pupil is very important because it clinches the diagnosis in most of the cases. There is a need for a multidisciplinary approach for managing these patients. As always, prompt diagnosis and treatment can improve the possibility of favorable outcomes. Thank you.
The case with bilateral papilledema hypertension, there is no PL in both eyes. Okay. There are two questions. If there is no PL in both eyes, how do you check the people? That is one. what is the cause of visual loss in this patient? There was also a venular block, no, in the,
There was a left transverse sinus stenosis.
okay. Now what is the cause of visual loss? In case of hypertension, accelerated hypertension with papilledema, we don't see visual loss to no PL normally, and that too bilateral. What is the mechanism of no PL in this situation? Whether papilledema patients over a period of time, we can expect the complete loss of vision. If you are untreated, you go for secondary optic atrophy and all that. That is the standard. What is the cause here?
Actually, sir, this was the case of fulminant IH. In normal IH, the vision is not reduced. Usually it is
No,
6
this is
or-
because of
Yeah.
disc edema or what? What else?
Yeah, so it's a combined thing. It's because of this hypertension which was there, which has led to this fulminant IH, one thing. And second thing is because of the CSVT on the left side. So that was the combined mechanism which has caused the vision loss.
What is the other case where the hypertension can cause?
That is a malignant hypertension.
No, no, no. What I mean to say is whether it's a type of AION. Because disc edema takes long time for atrophy and all that. But if there is a microvascular block which supplies the optic nerve in both
Yeah, we also
eyes,
did the other investigations which came out to be negative.
that's what I'm saying. You can't
Yeah.
explain the cause of, and with that stenosis, it doesn't cause.
Yeah, we have seen so many patients where because of the fulminant IH, the patient had either a hand movement or a no PL vision. And we did the bilateral optic with fenestration in these patients. Even after that, when the patient did not turn out, yeah, sometimes there is little
It's
improvement.
almost like a CRAO-like picture,
Yeah,
but the lesion lies somewhere else.
yeah.
And the hypertension is the cause, accelerated hypertension or malignant hypertension is the cause. But where is the lesion? The lesion is somewhere else which causes the supply to the optic nerve.
So what
So,
we,
so
yeah,
immediate loss of
we
vision.
talked with the neurosurgeon and they were of the view that left transverse sinus stenosis was the main cause, which was causing this.
Stenosis causing,
Yeah.
causing raised intraocular pressure and intracranial pressure
Yeah.
because of the flow is blocked.
That's why it's the fulminant IH. Actually, the definition of fulminant IH is that there should be sudden and rapid loss in the vision within a span of 4 weeks. Along with that, 40% of the patients have a history of hypertension. That's why, because in normal IH, there is very little or no diminution in the vision. Only in the fulminant IH variety, there is this diminution of the vision and sudden and rapid vision loss.
Thank you for the nice presentation. Next speaker will be Dr. Namatra Maji.
So, a very good morning to all of you. Before starting my presentation, I would like to ask all of you, how many of you want to give an unaided 6x vision to your patients post-operatively? 100%, I guess. So, the spherical component can be taken care of, but the problem lies with the cylinder astigmatism. The data has shown that 60% of our patients need astigmatism management, but only 18% of the patients opt for torics. The reason being, they are like costly, people can't afford. Inconsistency in toric outcomes, if we go wrong in any step, there can be surprises. If at times it is our fault, we assume that the minimal amount of astigmatism is insignificant, but it can be significant for the patient. And one more important reason is irregularity and asymmetry of the cornea for toric IOLs. To combat all these problems and pitfalls, Team Alcon has come up with one solution, that is Argus. Hello everyone, I am Dr. Namrata Maji. I have my own practice in a remote area of Odisha, that is Jaipur. So I'll be talking about Argus optical biometer. It's a sponsored talk. So how Argus has helped me improve my practice? It's faster and easier to use. It's measurement acquisition, real-time OCT guidance, Alcon Vision Planner software, the image-guided integration to my OR. That has helped me to give an unaided 6/6 vision to my patients. So let's start. It's less than 1 second. In fact, to be very precise, 0.6 second. In that minimum point of time, it captures all these 9 parameters that you see here. It has a very faster scanning speed, 3000 scans per second, faster acquisition speed as compared to the other optical biometers that are available in the market. And this is how it goes. Just a flick of light and the scan is done. So we have seen that it significantly reduces the time that is needed for scanning, with 41% of higher acquisition rate in grade 4 plus cataracts. It has a real-time OCT guidance which measures angle to angle and cornea to retina in a real-time OCT guidance. The image can be captured and reviewed and analyzed later after the patient has gone back. So this green thing that you see here, it indicates the patient's the cornea, the distance of the cornea from the device. This thing indicates that the patient's cornea is optimally centered. It detects small degrees of lateral movement also. Few vitreous anomalies can also be seen like asteroid hyalosis. This thing shows the retina. At times we can also see the macular holes in it. Obviously we need to zoom the image. And if at all this retina thing is not clear or if it is blurry, this gives an option here. There is enhanced retinal visualization, the ERV mode, which needs to be clicked, especially in the higher grades of cataract. So you can check for any tilt or any angulation that has happened. If there is any poor alignment, you can see here. You can review the measurements and outliers and deselect whichever is inaccurate. These are the quality indicators and the warnings that help you to identify poor measurements. You can refer and see the reference image to confirm whether the patient was cooperative or not, or how was the keratometry reading. You can confirm all the boundaries, whether they were detected accurately or not. So this is how it goes. Once the patient scanning is done, he has gone back, you come back to see how the thing was. I could see here the lens thickness shows the mark in red. So I go to the analyze mode, and here to find out what the problem was. I can see the red mark here. Rest 2 scannings were almost normal, but still shows an exclamatory sign here. What I do, I drag and drop where it should lie. Now it has come to green. Now this is the retina thing. We can also do the same with the retina and the cornea and other parameters as well. So the display shows left eye and right eye on both the sides for comparison. You can go to the keratometer to see whether these dots are properly aligned on inside the circle or not, whether they are sharp or not, and you can always go to the reference image to see how the anterior segment looks like. So once everything is done, everything is done properly, we click on the finish button and we see the lens thickness has turned green now. So this is how it helps us in precise measurement. The Alcon Vision Planner software, it has incorporated these all formulae, IOL calculation formulae. There's just one touch is required to plan for your surgery. You can plan your incision location, SIA, the preferred formula, the preferred IOL. And this is the beauty of this machine. You can manually enter the K reading, especially the patients who have undergone refractive surgery. You can check and from the pentacam and put the value, and the machine will calculate. So this is just an example to show how this thing goes out of the boundary. But we can see that was in the left eye. This is the right eye, which is proper. Now, as we go for the scanning, later on we are going to analyze what was the problem here. We see the axial length is proper, everything is proper, just the keratometry, the dots are going out of the boundary in the left eye. When we go to the reference image, we can see that there is a pterygium, and we found that it was a recurrent pterygium case. Now, the Alcon Vision Planner, it enhances residual astigmatism planning. It very nicely predicts the post-operative outcomes. You can, the spherical as well as the residual astigmatism warning it gives. You can plan for your toric IOLs if you want. You can drag and drop the primary and secondary incision locations. If you are a steeper axis surgeon, you can go for steeper, you can plan your incision accordingly, like this, the way the steeper axis here is 32 degrees, so I am planning, I am just dragging it here. But this is a right eye, obviously we cannot enter at 32 degree, but yes, we can go to the other side. The temporal incision was planned. Now, this is another case with cylinder of 1.88, and if we see with the toric, the cylinder has come down, but if we plan for any other monofocals, the cylinder has gone up to 2.12, more than what it was in other K readings. And this is a beautiful thing that I should show to all of you. It gives a planning of the paired incision. If the patient is not affording a toric IOL, then you can always plan for a paired incision here and put all your whatever you have planned for, you can put in here and go further with the limbal relaxing or corneal relaxing incision. So this is how the printout looks like. Integrated A constant and SIA calculators allow you to optimize your surgeon's constant, and now the Alcon team is going to come up with this plan. They are going to install the software into your laptop so that no need to sit in the OP to check and analyze the patient's data. The best part is the image guided integration to the Alcon cataract refractive suite. So they have a DMM which can be installed in your microscope in your OT. You can you just need a pen drive to export the data to your OT, and you can plan your surgery. This is how it goes. It shows where you want to put your incision. You can customize it according to your comfort. This is how the CCC goes, 5, 5.5 or 6, whatever you want according to your comfort. You can feed the data. And when we go for toric, we know that the manual markers come with some drawbacks, like there can be smudging of the dots, or they tend to fade away while you do the surgery, or if at all you have used a 26 gauge needle, it can cause a scratching and epi defect in the cornea. So if you have seen the cataract surgery that was done by experts yesterday, they have used this variance system. Here is the marking. They will show a line here, the marking you can align with them. It also helps in centration if you are planning for multifocal or trifocal IOLs. And this is how the Argus biometer with image guidance has helped me, because it is faster in preoperative measurements, it's easier to access, it has better acquisition rate, and the best part is it is fully integrated with the Alcon cataract refractive suite for better surgery, for more precision, and to give patient satisfaction. Thank you all for your patient hearing.
Question from the audience? Yes, what is the cost of this?
I guess Alcon people can guide you more with that. I've got it, sir, in my setup.
But in case mature cataract or a hypermature cataract, there will be no reading, I think. On
Uh,
post to polar cataract,
Ma'am,
they have
as
some
I
problem.
showed here, there is one ERV mode. If at all the retinal image on the OCT is not clear, then you can always switch on click on the ERV mode and it takes reading. But yes, of course, I do agree that you have to further go for ultrasonic biometer
Because
to
mostly
compare
post to polar
the.
cataract and all these things, that
This
light
is
might
this is
show you.
yes.
It's light
yes.
guided, that's why.
Yeah, but this has a better penetration rate compared to the other optical biometers, and that is how it goes. Thank you. Yes. For the nystagmus patient, it is difficult in any biometer. It is difficult for them to focus. But yes, you have a point. You tell them to close one eye and look at a particular point. It can capture in just 0.6 seconds. So wherever the eye is, still it can capture all the 9 parameters that I showed. Thank you.
Thank you, Namrata, for their nice presentation. Our next presenter is Dr. Sushant Pujari.
Photo ତାପରେ ମୋର ଅଛି ବୋଧେ ତାପରେ next 10ଟା start.
to change over. So good morning one and all. So one OPD story. There is a 28-year-old male chronic smoker, alcoholic since 10 years with no systemic illness come to our OPD with sudden painless loss of vision since one day after waking up from the sleep. So there is no other systemic complaint. Family and past history not significant. Vitals are stable. So visual acuity in left eye is 6/6, right eye PL positive, PR inaccurate, IOP 14 millimeter of mercury. Fundoscopy shows a cherry red spot and whitening of the retina. So on further systemic evaluation, chest X-ray showed cardiomegaly and ECG shows right bundle branch block. So what diagnosis and what we should do next? So first, Von Grab describes CRAO as an embolic disease caused by endocarditis. Then ophthalmoscopic picture can be described by Swigger. Then main research and publication is done by our own Swan Singh Harre, and he is the pioneer of retinal vascular occlusion and done many research on animal and prospective studies. So what is the epidemiology? CRAO is common in 1 in 10,000 of patients, and males are more commonly affected. Mean age of onset is 60 years. Right and left eye equally affected. But in BRAO, the right eye is more commonly affected because there is a chance of cardiac emboli travel directly to the right carotid arteries. Then arterial occlusion, there is early coagulative necrosis of the inner retinal layer. Then diffuse area of necrosis associated with intracellular edema that leads to intense retinal whitening, and diffuse acellular zone replacing the nerve fiber layer, ganglion cell layer and inner plexiform layer. Then if it is a chronic one that is more than 6 weeks, then optic atrophy, collateral around the disc, absent of foveal reflex, and NVD and NVI can be occurred. Then what are the risk factors? Old age, male gender, smoking, hypertension, obesity, diabetes, hyperlipidemia, then cardiovascular disease, all are risk factors. So mainly caused by emboli, that may be cholesterol, fibrin, calcific, or maybe, so there are many systemic diseases associated with this, like embolic sources, diseases, and trauma, coagulopathies, ocular conditions, certain ocular conditions like peripapillary arterial loops and collagen vascular diseases and other miscellaneous causes. So, according to the Dr. Harre, types of CRO is atretic, non-atretic, cilioretinal sparing or transient. So, the history is typical. Patient will tell you that there is a visual loss typical of switching of a light bulb. So, it is painless, and if it is painful, then ask for unilateral headache, scalp tenderness, jaw claudication. So, that will lead to giant cell arteritis. So, past history also important. Similar episode in the past, or TIA or stroke, or history of diabetes mellitus, hypertension, or any coronary artery disease should be asked. Then what are the signs? There will be profound vision loss, the counting finger to PL, and there is a presence of RAPD. If it is late, then NVI may be seen. Then fundoscopy, acute phase, there will be splinter hemorrhage around the disc, arterial attenuation, box clearing of the retinal vessels, posterior pole, whitening, and cherry red spot. Then in chronic phase, retinal whitening resolves and foveal reflex become absent, and there will be atrophy of the optic disc, and presence of NVD may be seen, and collaterals. So, this is a picture showing retinal whitening and a cherry red spot due to edema of the surrounding tissue. So, if cilioretinal artery is present and spared, then you may get a good perfused area. So, this is a picture showing Hollenhorstberg, that is nothing but a cholesterol emboli, then platelet fibrin emboli leading to BRAO, calcific emboli leading to CRAO. Then this picture showing box carrying of the retinal arteries, NVD, NVI, that is sequelae of a late presentation. And then what are the investigation? Visual field defect, you may get a central scotoma or a paracentral scotoma. If cilioretinal artery is spared, then you may get a island of well perfused area. So in OCT, in early phase, we get the thickening of the inner retinal layer and hyperreflective inner retinal layer due to edema, and in chronic phase, we may see the atrophy of these layers. So in FFA, we may see delay in choroidal filling in atretic type, which can be differentiated from the non-atretic type. AV transit delay, late staining of the disc, and masking of the background choroidal fluorescence by retinal edema. If cilioretinal artery is present, it may be seen in the early phase. So fundus autofluorescence, in acute phase, we get a hypoautofluorescent nor perfused retina, but a hyperfluorescent of the etiological plaque can be seen. Then in ERG, we may get a decrease or absent B wave, but if there is a ophthalmic artery occlusion, then we may get a both A and B wave diminution. So all the systemic examination should be done, like carotid Doppler, echocardiography, and coagulation profile. So management time is precious. It should be done within the 90 minutes, and the primary goal is to vasodilatation, removal of the clot by lysis, or there may be decrease in IOP, so that the emboli will be dislodged. So first we should go for carbogen inhalation, ask the patient to breathe in a paper bag or into his own cupped hand. Then start digital message, palm pressure over the eye by 2 fingers for 10 to 15 seconds and suddenly release. And this message should be continued till paracentesis is done. Paracentesis is done with 27 gauge needle and remove 0.5 ml of aqueous, and message is continue and breathing in the bag. Sublingual sorbitate, nitroglycerin, IV acetazolamide, rheological agent like IV pentoxifylline can be given, and all the measures should be continued, and look for if there is embolus is dislodged or the retina is perfused, and we can repeat the paracentesis after 30 minutes. Then we can go for a TPA therapy, but it requires specialized institution and also risky one. Then what is the prognosis? Most of the CRO obstruction results in severe and permanent loss, but prognosis is good in case of relatively good in BRAO or cilioretinal active occlusion. So take home message is CRO is a true emergency and treatment should be started promptly. It can be done in peripheral center or in OPD setting or a emergency room. We have to do a carbogen inhalation, ocular massage and IOP lowering agent. So complete recovery can be occur if ischemia is reversed within 90 minutes and some improvement still possible up to 40 minutes. The goal of the treatment is to dislodge the embolus, lower the IOP, vasodilatation and maintain the retinal perfusion. So regular follow-up should be done for the sequelae like NBI and thorough systemic evaluation should be done because it carries a high risk for stroke. Thank you.
So we are running late.
CRA can occur in post-anesthetic spinal or general anesthesia?
Yes, sir. Yes, sir. Any embolus can travel and can cause. Retrovalvar can be also, injection can cause CRA.
Next presentation. Presentation 11 ತಗೊಳ್ತಾ. हाँ फर्स्ट डेट हाँ तो ये presentation 11 बोल प्रेजेंटेड 11 बोल लिखा है 11 हाँ 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 डेस्कटॉप रख दीजिए हाँ मत देखा ओके Sorry, we are running late, around 10 to 15 minutes. So I will complete within 2 minutes. Okay. So recently we all celebrated the Deepavali very happily. So there will be some accidents giving rise to these firecracker injuries. Firecracker injuries are accidents that can happen any time. Okay. So mostly it happens during the 1 week of Deepavali, previously or after that it occurs. So all the patients have a different types of visual outcome. Every person, any specialty are required for the treatment. From starting from cornea to the retina, there is a combined effort to treat a firecracker injury. So there is an accident in the Deepavali night in Bhubaneswar. Around 50 injuries are reported. Out of that, around 30 are ocular injuries and 2 deaths are reported from Bhubaneswar. So normally there are around 10,000 injuries occurs during the firecracker during the week of Deepavali. Out of that, 17% are ocular injuries. And next to the hand and the hand injury and finger injuries, next to that, ocular injury is the most prominent. So all the patients that is coming to the MKC medical colleges are included in this case series, mostly from 28 October to 3rd November. So in this week, we got 36 patients to the OPD having different types of presentation of firecracker injury. So mostly the males, because they are doing the fireworks more, that's why males are compared to higher incidence as compared to the females. The young age, around 20 to 40 age group having shows the higher incidence as compared to the others. The most presentation, if the visual acuity at the presentation is the most prognostic sign, what is the outcome? So a patient presented with a good visual outcome, the prognosis is good. If the patient presented with a bad visual outcome, then prognosis is very bad. So mostly in our case, we have good visual prognosis. Only there is a open globe injury, only 5 cases are reported. That's why they have repaired and referred to the retina specialist. So what are the different types of injury in this that occurs in 36 patients? That is a contusion or with superficial foreign bodies and multiple trauma near the eyelid, lamellar recession like subconjunctival hemorrhage or some conjunctival tear or some amounts of partial thickness epithelial defects. Then superficial foreign bodies mostly in the cornea and conjunctiva. The next one is intraocular foreign body, mostly superficial foreign body or up to the level of anterior chamber that is removed by anyhow, but it goes to the posterior chamber, then it became a difficult one to remove, and the prediction to the visual outcome is also very difficult. Closed globe injury like hyphema because of the concussional and blunt trauma, hyphema, and angle recession are the cases, penetrating trauma and perforating trauma. So mostly patients, we have only 3 to 4 closed globe, open globe injuries. Closed globe injury around 4. Most of the patients presented with superficial burns and superficial foreign body in the conjunctiva and the cornea. So this is few case reports having some abnormality. So this is a case. Here there is a case. There is posterior sclera tear starting from the limbus with hyphema, and there is a vitreous leak. Here is the vitreous is there. The vitreous leak is there. So the patient come with a vision of hand movement. Then we do the B scan. B scan shows vitreous hemorrhage and there is a scleral tear. So as soon as possible in the next day, but in the next day we prepared that scleral tear was repaired in the hospital. After that again we do the B scan and find out there is a retinal detachment, and the patient was transferred and to the retina specialist. Other patients, most of the patients, this is patient with a charring of the eyelid with having multiple epithelial defects and the foreign body. So copious irrigation with the scrapping of the epithelium with the patent bandage and steroid drops. After 2 days somewhat it is healed and the vision is quite good. Third patient present with a concussional injury with the multiple foreign body and some amount of intrastromal foreign bodies are there. We try to remove all the foreign body in the first setting, but it's unable to remove all this because some of the foreign bodies are intrastromal. Again in the after 7th postoperative day, we have some of the foreign bodies became superficial. Then again the scrapping was done and foreign bodies were removed. But the visual outcome is somewhat 612 to 618. This is a devastating injury with a but luckily the patient has no eye injury. Though there is a severe facial injury, but ocular injury is very not so severe. Only there is a superficial foreign bodies and foreign bodies in the conjunctiva. So this is managed somewhat in the topically, and again in the OT we have removed all the foreign bodies. So the result shows that most of the affected patients are in the lower age group, mainly middle age group, around 20 to 40. So they are affected. Bystanders, they are who are looking to the Deepavali, that is, they are more affected as compared to the igniters. Igniters have a more head injury as compared to the bystanders, and the bottle rocket injury and the bombs are the more dangerous one. So we can only treat after the accident happens. So we have to go for the prevention. So I will complete it. So what are the things we will do? Receive the firework injury. If you receive it, so wash your eyes with clean water. Don't rub your eyes. Cover your eyes with a protective shield and start immediate medical attention. Don't try to remove anything inside the eye, so that may cause further injury to the eye. So these are the prevention strategies. So children should be supervised. All the things are, you have to single, and most effective method is to restrict the firework in an open field, or if you do it with a protective, and there's a regulation for the quality to forms the fireworks should be very strict, so that the damage should be, and homemade firecrackers should be avoided to decrease the number of injuries. Thank you.
eye wears, actually safety eye wears can be wear. But safety eye wears does not mean that there is a protective glass or sunglass like that. That will not going to help anymore. When there is a blast, there will be injury by the glass also. The glass will damage more. Yes, because they are very, because they try to ignite the things to which are already. Thank you. We will conclude this session and the next session will be start so that I think we will felicitate all the speakers, then we will conclude the session. I will call JP Behra sir as Gunsagar sir to felicitate all the speakers. So please. Dr. Pranal Verma. Dr. Sushil Pani sir. Dr. Namrata Maji. Dr. Susan Vijay. Dr. Shrutileti Parina. Eminent and real ophthalmologist. This session is concluded and the next session will be started by Kunal.
Thank you, ma'am. So we'll start the next session is Odisha blindness control. I would like to call Dr. Ajit Babu sir to chair the session. The first speaker for the session will start with Dr. Syed Ayaz Hussain.
Hello, good morning everyone. I am Dr. Syed Ejaz Hussain from Barampur, Odisha. I'll be presenting on the topic of performance advantage with lesion ecosystem and how it enhances the surgical outcome. I have no financial interest to disclose. As a phacosurgeon, we all know that the best outcomes come when our skill is backed up by a good phaco machine. A good phaco machine is one which keeps your surgical field stable and helps you battle even the densest cataract. It thus increases the efficacy of our regular phacos as well as complicated one which otherwise would have been very difficult to manage. What you can see on the screen is the new Legion phaco system. Legion has the advantage of being a compact portable design. The Legion phaco system is designed for easy transport and use in various surgical environments. Coming to its compact design, like you can see, it packs up into something of the size of a cabin luggage and is conveniently portable. It uses the state-of-the-art Centurion-based fluidic management system. It features a user-friendly graphic interface that simplifies operation and allows for quick adjustment and customization of surgical settings and parameter. As you can see, it's being used in my setup and the screen even folds down. So it's like very easy and you can carry it very portably. So coming to its enhanced fluidics, it has an optical vacuum sensor which efficiently detects vacuum in aspiration line. It also has a rotary vent valve which overcomes this vacuum by releasing extra fluid into the aspiration line, a process that is called venting. That helps in keeping the anterior chamber stable and reduces chances of surge formation even in harder cataracts, thus reducing the risk of PCR. This enhanced anterior chamber stability also helps with faster recovery from surge and reduced surge impact. It has both torsional and longitudinal cutting technology which efficiently cuts through hard cataracts as compared to the older systems. As you can see in the above video of a torsional phaco, having a very good cutting ability, it will be seen. And it has a very less chatter compared to the longitudinal phaco machine. And just forward. This is the cavitation being formed. And as you can see in here, there is more repulsion and chatter in the longitudinal when compared to the torsional one. This is done under very high magnification phaco video. And hence torsional system, because of its optimized cutting efficiency, it also reduces the surgical time and leading to a lesser amount of endothelial loss also. It has lower temperature rise, especially at the tip, which helps with better wound integrity. It also has improved holdability and followability as is demonstrated in the next slide video. This is a grade 4 cataract being operated by me on a Legion phaco machine, and you can observe the firm hold and cutting ability which helps in easier job and reduce stress on the zonules. As you can see here, the nucleus is not being pushed back too much, and it's easily having a good hold and helps in an easier job. And this is a next case of mine, which is a leathery brown mature cataract that is being operated. Such cataracts are notorious for the difficulty in phaco division and hold, but as here we can see the chop and separation of the nucleus pieces, which was quite easy. It had very less phaco time also, had a very clear cornea the next day, even without the use of any visco-dispersive and use of visco only once during rhexis formation, thanks to the torsional system of the Legion. This design also has a dual segment and 7-roller peristaltic pump, which leads to a smooth, fast fluidic response, allowing for enhanced followability, which can also be seen in my next video. In this video, you can see the good followability, which helps in bringing the nuclear pieces towards the probe with minimum chatter. As you can see, the probe remains in the center while the nucleus pieces follow. Follow one after the other to the near to the tip of the probe. So the lesion phaco system features an intuitive interface that simplifies navigation and operation for surgeons. This innovative tool allows surgeons to tailor surgical procedures according to the individual patient needs, enhancing precision. This is how it looks on the screen. And finally, coming to the conclusion and takeaways, it has a superior chamber stability and surge protection, optimized cutting efficiency with reduced thermal risks, enhanced user experience and customization options for better precision in surgery. These are references, and thank you very much. Any question?
How do you ensure chamber stability
Sir,
in lesion?
So the system itself has means the rotary vent valve system, and because of the same chamber, because it's a light sensor based system. So when as soon as it gets blocked by 90% or more, with more precision, the negative means the fluid is injected into the system, and we maintain a proper balance. Even in the means quite a good balance has been maintained to prevent the PCR.
Where is the sensor? Means, see, the thing is, this whole system is there, and
Yes.
the system need to have a sensor first of all.
Yes, sir. It has a sensor in the cassette system, sir.
Cassette system.
And you can.
And the infusion, where do you need to keep the infusion?
Infusion, sir.
Especially- Yeah, BSS. What?
BSS, we are using the BSS, or even if you don't have it,
where
you can
to,
go
where
for
to keep? Outside or
outside.
there is a
Also.
chamber?
Outside, sir.
Separate chamber is now.
No, not there, sir. In the that's there in the Centurion-based system.
Centurion, yes, yes.
Centurion system also, it has two. One for the active one, you need to keep it in the chamber, but for the normal gravity base, that's two is outside only. But the advantage with the Centurion compared to the Legion is that in the Centurion-based system, you can attach means every procedure you can set the bottle height. But in the Legion-based system, you'll have to
It's not
separately
required. Once it is, yeah. Once the sensor is built in,
yeah.
it is not required for the
Not
height of
required for the gravity-based system so much, and even if you do want it, they don't market it in India, but from US it costs around 10 lakhs or so for the stand that you have to get. Okay, so thank you, sir.
Thank you, Dr. Saeed. Next speaker is Dr. Devadatta Das. Over to you.
Thank you, Dr. Kunal. Hello. The topic I am going to present is actually not so documented, so I would like to have a guidance from other doctors and my seniors. If they have any data regarding this, they can guide me better. So my topic is challenges and the future measures to undertake for Odisha blindness control program. Myself Devdutt. National Program for Control of Blindness aims at providing universal eye health services to one and all, conduct eye screening programs at various levels, promoting eye donation, training of surgeons, and involving functionaries from panchayats, ICDS staffs, ASHA workers, NGOs, and voluntary groups. Present scenario of NPCP is we are reducing the burden of cataract by providing quality services. Currently, it is funding for the management of diabetic retinopathy, glaucoma, ocular trauma, childhood blindness including the ROP, keratoplasty use blindness control, squint screening, evaluation and possible treatment, low vision assessment and its management. Odisha Blindness Control Program started in year 1976. Initial objectives were to reduce the prevalence of blindness in the state primarily through cataract surgeries, eye care services and public awareness campaigns. Blindness burden in Odisha is not documented so much in literature, so no published documents are available. I got an article from Times of India newspaper published in 9/8/2004 that over 5.2 lakhs people are blind in Odisha, which includes 2 lakh young population. Huge disparity in incidence of blindness in urban versus non-urban population. Difference in incidence of blindness in tribal, that is counts to around 4.7% as compared to non-tribal, which is 0.8%. So the challenges which are being faced by the Odisha Blindness Control Program is insufficient funding and resources from the state government, inadequate healthcare infrastructure, usually in the rural and the remote tribal areas, lack of necessary infrastructure and shortage of trained personnel, limited public awareness. There's actually huge masses of our population who are unaware of the services being provided by the state government, and the importance of early detection and treatment of eye diseases is lacking. And the major cause factor is low literacy rates among the people. There's a high patient load. In some districts, the load strains are so much that they strain the existing resources, leading to delay in availing the services. Screening and follow-up challenges. Screening programs often struggle to reach all the population, and follow-up services seems to be inconsistent, especially in tribal and remote regions. Lack of proper data and data reserves and monitoring. Efficient tracking and monitoring systems are limited. Hence, resources allocation is a big challenge to the government of India. Socio-economic barriers are a big one. The poverty is the one and the foremost cause. Associated costs of treatment other than provided by government is not being able to bear by the patients. Transportation costs adds to the glare. Absence of work for 1 day leading to 1 day wage loss is a big psychological impact for the patient. So measures to be taken by Odisha Blindness Control Program is, it has to be a better funding facility, improved infrastructure, targeted awareness campaigns, enhanced coordination between the government and the NGOs. I find, because I am practicing in the periphery, I find that glaucoma, hypertensive retinopathy and diabetic retinopathy and ROP in rural population is being a major block in the prevention of blindness. As of 2024, OBCP has achieved several milestones, like there has been an increase in the number of cataract surgeries, especially in the rural areas, enhanced screening initiatives by the government, which includes expansion of eye screening camps in schools and communities leading to early detection and treatment, especially in children, increased and improvised awareness programs being started by the government. There is regular training of the healthcare professionals. Meticulous partnership with the NGOs have strengthened outreach efforts and has provided additional resources. Improved data collection has started, and more focus has increased in tribal and remote areas. Mobile end clinics have been deployed to remote tribal areas, and the increased telemedicine services have started in various government institutions. Thank you for your patience hearing.
I am also new to Odisha state
thank you
in
for
terms of rural public health. Actually, this is another opportunity for me to go into the rural areas and explore the rural Odisha. But what is the budget, that is annual budget, that is allocated for eye health
So,
in
the
the state budget?
the budget allocation percentage is not fixed, sir.
Percentage is not required. Last
sir.
3 years or 4 years, how much budget has
It
been
counts
allocated?
around 7% of the total.
7% is a huge amount.
But
no,
the-
that is for whole health.
Whole.
I'm asking for eye health.
Eye health is 1.3%.
1.3%. That comes to how much in terms of money? No, just to have a measure of it. That's it.
1.3%. They are selling around 300 crores for.
300 crores is huge.
I don't know
We
where the
can
money
do
goes.
miracles. If they give me 200 crores, not 300, I will take each district and change the whole Odisha health.
It's like the chain. Where does it
infrastructure,
end?
yes. Huh?
I'm just hinting at
No,
the
no.
chain. Where does it end?
Yeah. No, but the thing is, what is the major deficiency? You said is screening programs. The people cannot go out for a very long distance. So there should be an infrastructure, should be
Yeah, it's starting to build up.
nearest pa-
It's
nearest
starting to build up.
places.
Like I'm working in 2 districts in the periphery.
Yeah.
What I find is the mobile clinics and the screening programs have increased. In the last 5 years of my practice, I've seen that where right from 2018 till date, I find that I have seen people getting more screened for their disease.
Yeah. Especially this availability, again, I have some measure of it. It's mainly, need to come twice or thrice a month,
Yeah.
but on a fixed days.
Yeah.
If that is coming, at least they will have access. And in the public also, there is a feeling that today it's coming, so I need to stay.
Yeah. That part is lacking, sir.
That-
Suppose
that
you
you are saying from the medical side, I am saying from the rural side,
No,
the population side.
So when-
population have the awareness.
From-
If you are giving free medicines, they are waiting for it and collecting. From the population, it is there. The percentage need not be 90 to 100%, but mild percentage, but they are aware and they are ready to take the facility. If free medicines also given, it's only screening. Most
medicines
probably
are not
wrong.
being given, sir.
Yeah, that's what
free
that
medicines
need
are
to be
not-
done.
Yeah,
Actually.
free medicine.
Okay, thank you.
Thank you, sir.
Yeah, next. I will stay till only 11 o'clock because मेरा session उधर है. I was a last minute replacement.
Dr. Devadatta,
Sir.
I have a question.
Yes, sir.
Not regarding your presentation,
Sir.
but if you find for the last few years, the rate of cataract surgery done by NGOs is decreasing, and maybe one of the factors is there are several hospitals which operate under BSKY or now Ayushman Bharat, but they are not operating under NPCB. So if you see,
Sir, the thing-
wait. If you see NPCB surgery part is very less, very, very less, and insurance part is very much, because obvious through insurance they get more, but through NPCB they get only 2,000 rupees. So do you suggest anything, or do you?
Sir, the first thing is all in the currency notes. The story starts.
No, all in our hearts.
Yeah.
Who is deciding this? Tell me. I'm asking you, who is deciding this? I will go for NPCB or insurance. Who is deciding? Tell me. Not political parties.
Yes, sir.
Let us be honest. We are also honest human beings, right?
Yes,
Who
sir.
is deciding?
Yes, sir. That I am asking that we should make the NGOs compulsory to do under NPCB.
No, sir.
Not required, sir. If we are, as an ophthalmologist, if you are having your own clinic and if you are doing under an NPCB, be it's little amount, but you are serving a person who is totally deprived of any facility. So you are extending one service, second sustenance of yours. Whereas insurance is for rich people, right? Not poor people will have the insurance. So both we need to have that kind of a heart to serve, especially rural areas. When we are going little bit,
Sir,
we need to have
Odisha has around 4.69 crores of population. As per the BSKY distributed cards, it covers around 2.96 crores of people. So 2.96 percentage of the persons who have been distributed card, they have in their mind that this card is meant for health checkups. So they are more focused ki I have a problem, I have this facility, I need not spend a penny. I have to go and get my free services done, and they are on the focus bang on the hospital. But the persons who have divided of cards, that they usually in such a place, you'll find that still the civilization has not reached there. So when you go there, no, they don't know that the government provides free services to the areas. I say like districts of Keonjhar and everywhere. If you go to the remotest village of Keonjhar, they don't know what is the government services being provided. If I tell them, my people, I don't go, but when my counselors go there, when they tell that you have a problem in the eye, so his first question is, should I pay? First question, whether I will get the food.
No, see the thing
Are you
is-
going to pay me the wages? So these are the questions very difficult to answer.
Yeah, if it is 1.25 crores which is need to be distributed with cards, which again the health system can take it as a challenge and complete the distribution of the cards. At least one mind block will go away.
Go away.
That we need to bring to the
Notice of the
administration.
government.
Yes, 100%. At least
And the
this
second
will
thing
help
is,
me.
sir, budget.
Thank you. I think time is up. We need to. Yeah, next
NCCV
speaker.
payment comes after 6 months, and this comes after 1.5 months. So this biggest advantage.
Thank you, Dr. Das, for such a elaborative topic.
First 6 months
It will
we need
never
to
end.
go.
Next speaker, I would like to call Dr. Ajay Kumar Singh for government initiatives of private-public partnership in blindness prevention. Thank you.
Good morning. So, my last speaker, Dr. Devata sir, has described the problems which is going on in Odisha, and myself, District Program Manager DPM in one district, that is Khorda, working since last 5 years there, and I will highlight some government initiatives and public-private partnership in blindness prevention in Odisha. Odisha, an eastern India state, is making significant strides in blindness prevention. Through government initiatives and public-private partnerships, the state aims to reduce preventable blindness and improve eye health care for its population. The current state of blindness in Odisha, Odisha faces a high prevalence of blindness, particularly in rural areas, what is discussed now. Cataract remains the leading cause of visual impairment, and access to care, unreachable area, what is called as limited access to eye care services in remote regions exacerbates the problem. Many residents lack awareness about preventive measures, just discussed previously. So economic impact, blindness significantly affects productivity and quality of life. It possesses a substantial economic burden on families and state. So cataract, the primary cause of blindness in Odisha. Age-related cataract affects a large portion of the elderly population. Similarly, not only cataract, refractory error also, uncorrected refractory errors leads to visual impairment in many cases to go undiagnosed due to lack of screening. Other conditions like glaucoma, diabetic retinopathy and corneal blindness contribute to the state's blindness burden. Early detection is crucial. So government vision and strategy for blindness prevention, comprehensive eye care. The government aims to establish a robust eye care system. It focuses on prevention, treatment and rehabilitation services. Awareness campaigns, launching statewide awareness program to educate the public. The goal is to promote early detection and treatment. And then infrastructure development, investing in eye care facilities and equipments. The strategy includes upgrading existing centers and establishing new ones. Key initiatives by the Odisha government. First, mobile eye clinics. In all the states of Odisha, 30 districts, 30 MO vehicles are there, mobile ophthalmic units. And those districts which are more than 10 blocks in Odisha, they are having another vehicle that is called MVC, Mobile Vision Center. 2 vehicles are also there. The ophthalmic assistants are posted and they are routinely, monthly 20 visits they are doing in the periphery. And a fixed vision center is constructed at the block level. Now there is problem solved due to Sunetro. Now this name is changed to Surendra Sai Divya Drushti Yojana, and in this way the fixed vision center is constructed and MVC and FVC, fixed vision center in block wise, and MVC is mobile vision center. That means one vehicle is there and if ophthalmic assistant is going and screening the cataract patients and also refractive error and other diseases patients are referred to the block district headquarter hospitals. Screening programs, implementing the regular eye screening in schools also and communities and distribution of glass. Early detection of eye problems is prioritized. In coming month, throughout the state, school eye health program, SCSP, is going to start since 3 years. This program is going on and all the school children, government and government aided schools are getting, students are getting spectacles in free of cost. And tertiary eye centers establishing specialized eye care hospitals in major cities. These centers offer advanced treatments and surgeries. Then it is also one going on teleophthalmology and also we know TOSI, Teleophthalmology Society of India. It is also a branch of telemedicine that enables remote area eye care services using digital technology. It allows healthcare providers to diagnose, monitor and sometimes treat the eye conditions without requiring patients to visit in persons. Images of a patient's eyes are captured often by trained technicians and then sent to an ophthalmologist for analysis. The role of public-private partnerships, you see, resource sharing. PPP enables sharing of infrastructure and expertise. Private sector contributes advanced technology and skilled professionals. Then quality improvement. PPP brings best practices from private sector. It leads to improved quality of eye care services across the state. The expand reach, collaboration extends service to underserved areas. Private partnership help in setting up vision centers in rural regions. And cost-effective solutions, partnerships reduce financial burden of the government. Private sector involvement makes services more affordable for patients. These are some successful PPP programs. Challenges and barriers in implementation, geographic barriers, workforce shortage, and cultural beliefs. Future outlook, technology integration, capacity building, and policy enhancement. In technology integration, implementing telemedicines and all India-based screening tools. Capacity building, investing in training programs for eye care professionals, and policy enhancement, refining policies to encourage more private sector participations. And Vision 2020, the rights to sight, this is global initiatives, collaborative efforts, and sustainable impact that everybody knows. And special action taken by the Odisha government, that is PVTG, particularly vulnerable tribal groups. In Odisha, so many districts, minimum 10 to 12 districts where particularly vulnerable tribal groups people were there. In Raigada district, Odisha eye health programs are implemented to address the needs of particularly vulnerable tribal groups, including the Dangaria, Kandho, and Lanja Sura communities. These efforts involve collaboration with organizations like Mission for Vision and LV Prasad Institute, which run outreach programs to improve eye health awareness, conduct screening, and provide essential eye care services in remote areas. And diabetic retinopathy screening, also government supplied fundoscope machine to every district headquarter hospital, by which we are selecting one day, suppose Tuesday in every week, we are calling the diabetic patients and we are doing the fundoscopy test, and any diabetic retinopathy, we are referring the patients to the higher institute. And keratoplasty, people should know that what is blindness due to cornea, or that means corneal blindness. In Jatni block, Odisha, Khordha districts, government started home-to-home visit by the ASHA workers, selected the blindness due to cornea. And 18 patients are selected and they operated in free of cost in LV Prasad. That means people should know what are the blindness that can be prevented. But we are organizing eye donation fortnight, August 25 to September 8, but cornea is collected, but people don't know whether they will be improved or not. This conclusion, progress and promise, strengthening infrastructure, empowering communities. Thank you. So regarding financial benefit, that's last sir is telling that actually 600 crores are supplied, budget was approved for Sunetra program for last 5 years, but due to so many barriers, money was not expended. Till now, every district has 1 crore. Like suppose my Khordha district, I have 1 crore last 3 years, because due to so many problems, infrastructure, engineering problems, the infrastructure has not been developed. And monetary problem like BSKV and my sir told that BSKV and NPCVI. NPCVI, National Program for Control Blindness, that is giving 2,000 to every cataract patients, but in BSKY, 7,500 rupees previously, now 7,725 is giving. So automatically, hospitals are opening due for this only financial benefit. So I think if this is going on, within 5 years, Odisha will be cataract free definitely, because NPCVI is giving 2,000 and now Ayushman Bharat it will give 7,500. So previously people were going to hospitals for surgery, but now hospitals are opening for the surgery of the cataract patients.
Thank you.
So no financial problem. Thank you.
Thank you, Ajay sir. Next speaker I would like to call Dr. Sujata Priyambada. The topic is comprehensive eye examination in CAM patient, cost-effective cash at contact. Thank you.
Good morning, everyone. My topic is more on capacity building and how to utilize the resources from a perspective of a private medical college. Yeah. So I'll be dealing on comprehensive eye examination in patients referred from camp. The World Health Organization says that a strong and equitable eye health system is based on 3 pillars: to measure the disease burden in the community, developing human resources with training in comprehensive eye care, and providing eye care to each and one. Now, in today's perspective, we have a plethora of eye camps, starting from a generalized eye camp like a vision screening camp, to a cataract screening camp, to a specialized camp like a diabetic retinopathy screening camp. Then we have an opportunist camp like a workplace eye screening camp. But what is a comprehensive eye camp? A comprehensive eye camp deals with several types of services which if not treated, will lead to visual disability or blindness. Now, why the need for eye camps in today's perspective? According to National Blindness and Visual Impairment Survey, the rural population has 1.18 times more blind than the urban population. And if we want to reach the facilities to the rural population, we cannot depend on only those who come to the hospital. Rather, we have to provide a community-based eye service. Now, the accessibility and accomplishment of an eye care service depends upon the number of cataract surgeries performed. And the outcome of cataract surgery is directly proportional to the pre-existing ocular morbidities. Therefore, the need for an extensive and a comprehensive eye examination in referred patients. So, in this era, why don't the rural patients still reach the base hospital? Either due to the apathy or inertia of not going, maybe financial constraints, transportation, elderly patients, females, the myths or stigma associated with cataract surgery, and finally, in the era of BSKY, wait and watch. Someone will come looking for us. Now, comprehensive screening camp versus a comprehensive examination. The mission of a comprehensive screening camp is assessing refractive errors and primary eye care problems, effective screening, and then referral of patients with need and patients at risk. Whereas, a comprehensive examination of the camp patients will help to identify the comorbidities, the patients at risk prior to surgery, and will help to plan a protocol, whether to optimally treat or a prompt referral. And finally, training the trainees, which is the main role in a medical college. Now, ours being a young PG institute, we have the following outreach resources. We have a mobile eye van with an eye chart, autorefractometer and torometer, and a mobile bus which is attached with a dental unit. Partly it is a ophthal unit and a dental unit. And we hold camps with the help of NGOs and local authorities. as a part of a generalized health camp, school screening camp, or a cataract screening camps. Now, our team consists of registration and data entry done by the nursing students and nursing staff, ophthalmic assistant doing refraction, and interns and PG residents for screening of the patients. Now, how do I study the impact of this kind of screening? For this, a retrospective study was done from January 2022 to July 2023 in the patients referred from the camps. The methodology was simple. The patients were screened by either ophthalmic assistants, interns, or PG residents. Patients above 40 years of age who had best corrected visual acuity less than 6/18, rise in IOP or ocular complaints needing referrals were referred to the base hospital. The database of such patients were obtained from the hospital records and case sheets and compiled, and we made following observations. About 1/3 of the patients presented with some ocular comorbidities. The patients with comorbidities were statistically of a higher age group. Since the refraction was done in the camp, the refractive error was not a significant problem. The comorbidities were judged on the basis of the number of patients, and prevalence was calculated on the basis of patients presenting. Retinopathy was the most undiagnosed case in more than 25%, followed by post-surgical complication in nearly 11%. All the comorbidities were defined into anterior segment and posterior segment. Some interesting facts that came out were more than 70% of those with diabetic retinopathy were unaware of their conditions. The prevalence of post-cataract complications was at 3.57%, and 62% of them had PCOs, untreated PCO. The high prevalence of pterygium was found mainly because of the farming population. Another interesting thing was that even though 2% of the patients who had active keratitis and active uveitis in symptomatic phase, they did not come to the hospital. They still waited for the camps to conduct and bring them back. The distribution of glaucoma was about 1.64%, out of which PSEG was seen in a higher mean age group. Lens-induced glaucoma was a major cause of secondary glaucomas. And nearly 15% of those with glaucoma had already had glaucomatous optic atrophy. Our study also tried to classify the patients at risk factors of glaucoma into DIS suspects, ocular hypertensives, with angle closure suspects, and PX. Finally, a flowchart was prepared to distribute the patient, how much needed surgeries, how many needed a combined surgeries, how many were referred, and how many were referred for other surgeries. Now, what did I gain? The positive points from this study. Comprehensive eye examinations provides a window of opportunity to find the comorbidities that can adversely affect cataract surgery outcomes. Second is to identify the patient at risk. Third, to identify patient in a systemic disease. The advantage of being in a medical college, you can easily refer to a department of interest. To estimate the disease burden in the community, roughly, and finally, interns as a part of the eye care team. Now, according to the new Medical Council syllabus, EdCom forms an important part of undergraduate education. So what better they can learn communication and teamwork rather than being a part of eye care team. They act best as patient counselors. The limitation of the study were, since it was conducted in age greater than 40 years, it was incomparable with National Blindness Survey. It classifies comorbidities based on blindness. It was an opportunistic sample, so not a true representation, and follow-up data was unavailable. So it was time to learn for mistakes. There should be a systemic distribution of camp, both were geographically and time-bound, followed by follow-up. There should be a clear protocol when to treat and when to refer. And comprehensive eye examination in referred patients are important because very detailed examinations can hamper the objectives of screening. So comprehensive eye examination is a cost-effective and efficient tool to identify ocular diseases in a community like Sundargarh. It improves cataract surgery outcome by better counseling.
Dr. Priyamvada, I think you need to conclude. Time is up long ago.
It provides an holistic approach to undergraduate and postgraduate training and optimizes the management of comorbidities. Thank you, sir.
Okay, yeah. You are screening, this is a very good thing, but how are you proposing to follow if some patients you got the data, hard data that
Yeah,
which patient
this is a data
having.
which.
Wait. You identified certain person is having cataract. He may come to you or may not come to you. Second, there are people with comorbidities. If they are not coming to the medical college for the treatment, then how are you following them? How you are
Sir,
tracing
my
them
data
and
is based on the
bringing back?
patients who have been born from the camps to the base hospital. In the base hospitals, we divided them based on the comorbidities, whether they required only surgery. So we did that. If it is required surgery with something, with a trap, for example, we did that. For surgery followed by a retinal referral, we referred the patients to the hospital,
Whether
nearest
they are
hospital.
availing or not availing.
That is the issue with my study. We did not find a follow-up data of the patients who were referred.
That is mainly public health.
There are certain-
mainly that is lacking actually.
Yeah.
We always concentrate on one time and observational, and after that there is no follow-ups. So end result is not going to be so good. Even if you see, even in the medical hospitals or institutes, if the patient do not come for follow-up, how are the results? And they come for the follow-up, the results will change.
So actually, we and Shashwat are doing this. If I find a patient which I have operated on and I find that there is a retinopathy issue which needs, I refer the patient and I give a call to Shashwat that if the
Such and
patient
such
turns
patient
up,
will come.
if it turns up to him, he calls back to me. So we are trying to set up a referral system in that way. But in a setup like Sundargarh, where the patients are not apathic, are not interested in their eye conditions. So the referral system has to be strengthened.
These
to
are all
achieve eye goals.
small hamlets, and they all will have either teacher or a village head who are responsible. These people do not know. See, we need to understand their living conditions also. They do not know what is the importance, right? Being a healthy and a good feeling and being able to work and earn their living being itself is a big thing. For them, living being comes up in this ladder than the health. That's why they don't give so much importance. But we need to make it understand either the village head or an educated person who is responsible in that locale, then the things may change. Otherwise, it will not change.
So that is why I am wanting to introduce either the third undergraduate students or interns as patient counselors, and they will help in reducing the problems associated with compliance. So because they will have that patience to come, and that will be a holistic training from them in patient interaction, and that will be a patient-centered learning for them.
Okay, thank you. I think you call the next one.
Thank you, Sujata ma'am. Next speaker, I would like to call Dr. Gunasagar Das. The topic is Evolution of Eye Department at VSS MCH. Over to you, sir.
It will show here. Birth growth, this one, last one. Oh, hello, okay. तो नीचे जाएगा ना चेंज होगा
नीचे नहीं तो सर
अच्छा तो my dear friends, as we grow older and older, we become a storyteller. All the happenings that happened in the past become a story for us. So now I will take you down the memory lane to 70 years back about the Burla growth, birth, growth, and development of the eye department of Bhimshar, Burla, Odisha. So this is the author myself. So this is about the picture of Bhimshar, Burla and the hospital, Bhimshar, Burla. So the birth, actually it is the second government medical college of Odisha. It was started in the hospital buildings of Hirakud Dam project in Burla, just beneath the colossal world's largest dam on the bank of river Mahanadi in the year 1959. Later on, the college and hospital buildings were constructed. The eye department was born in the lap of the mother hospital. Professor Bishambar Rajguru, the centurion grand ophthalmologist of Odisha, was the first HOD from 61 to 65. So the equipments at that time were a table lamp, torchlight, binocular loop, direct ophthalmoscope, and a Sios tonometer. Next, HOD was Professor Kulamani Mishra from 65 to 68. Again from 68 to 70, Professor B. Rajguru. So from 1970 onwards, after doing a fellowship in Germany, Professor Yushi Behra performed 3 number of keratoplasty in one doctor, in an engineer and a businessman. 2 were successful. Probably this was for the first time in Western Odisha. Then again from 1970 through to 78, Professor Kulamani Mishra became the HOD and medical superintendent. He was a famous disciplinarian and able administrator, most popular medical superintendent. It is hard that once he held the anterior capsule by a capsular forceps, the lens was coming out without any effort as his hand was trembling. This is just a story. Next, from 79 to 85, Professor Yushi Behra again came. During his tenure, the Osokon was held at Burla in 1981, and Dr. Vijayananda Patnaik, the famous retina specialist of India, was the chief luminous speaker at that time. The department was having a Hack-Street slit lamp, Skippen's binocular indirect ophthalmoscope, handheld fundus camera, Goldman 3-mirror lens, contact lens, and an applanation tonometry. He did one RD surgery at that time, and I was present in the OT. He was my Gurudev. Then from 85 to 91, Professor Vibhudatta Das, during his tenure, one fluorescent angiographic camera operating microscope were installed. He performed 2 keratoplasty. The author was the assistant in one of them. Then Professor Sukumar Sarkar from 91 to 93. He was in charge HOD from 91 to 92. Professor Chandi Das was HOD for a short period. He again took over charge from 92 to 93. During his period, IOL implantation at DCR was established at Burla by a famous surgeon, Dr. D.N. Bhuya. From 98 to 99, Dr. Basanta Kumar Jena and Dr. K.S.N. Rao were in charge HOD. Dr. D.N. Bhuya, an eminent cataract surgeon, popularized IOL implantation and dacrocystorhinostomy in Western Odisha. From 99 to 2000, Shrikant Singh was HOD. Dr. Bishi Pradhan and Dr. Bhuya were in charge for a brief period. IOL implantation and DCR operation were much publicized even in outreach camps. Then Professor Lakshmidhara Mishra from 2000 to 2003. Again, IOL implantation and DCR surgery were very much popularized at that time. Then myself, the author, became the HOD, became the associate professor from 2003 to 2005. At that time, eye donation and keratoplasty was revived and established. It became a mass movement by a short film, Life After Death, Mrityu Parara Jivana, telecasted by OTV, based on a real-time eye donation story of Uttam Kumar Padhi from his deathbed and keratoplasty thereafter. Then from 5 to 2008, the virtual eye bank was registered by Professor Suresh Chandra Mahapatra the DMT Odisha at Burla out of good will only. And I became the first eye bank in charge. From 2008 to 2011 onwards, a state level seminar on eye donation, eye banking, keratoplasty was organized with the sponsorship of government. The eye bank was affiliated with the National Eye Bank Association of India. High-end equipments like vitrectomy unit, home perimeter, phaco unit, optical coherence tomography, fluorescent angiography unit, and etc. were ordered and procured and commissioned. Retina and vitreous surgery, phaco emulsification were started and established. From 2011 to 2012, P.K. Nanda and K.C. Tudu were there. And from 2012 onwards, Professor Jayashree Dora is still the HOD. All the high-end equipments have been installed. All type of keratoplasty, cataract surgery, vitreoretinal surgery are being done by the new generation. The eye department has actually developed. But the medical college has been transformed to Veer Surendra Sai Medical College, Bhimshar. And Professor Dora was the dean and principal in the past. In new campus with separate 100-bedded wing, suitable human resources development are needed at present, where all the specialized clinics can serve the people. This is needed. Thank you. Tamasoma Jyotirgamaya.
Thank you, sir, for enlightening the journey of a medical college. See,
Sir.
individuals is okay, but medical college journey is very, very essential. As you said, in the beginning years, we don't have the facilities, first of all. But at that time, the chief ministers and the government are very inclined, whatever you are asking. So why there was an inhibition in starting all the techniques which are present?
Sir, this is actually, the HOD should take the personal interest. That is lacking. When I was HOD, I had started specialized clinic, retina clinic, squint clinic, every clinic, with whatever the staffs available. But why the next HOD are not doing? It needs their special interest and mindset. They should do. I request the present HOD, Professor Jayashree Dora, she should take interest to develop. Now it is Bhimshar, like university, health and university.
I lost my cool. Actually, usually I am always cool. I take things, I note things, but I don't react to things. But yesterday, only 2 thesis papers were presented. Then I asked how many medical colleges in the state, right? And there is a possibility of 50 to 60 thesis presentations can be possible in that session. If so many are there, then we will look for the quality and contain the number of thesis presentations in that session. And we come from outside, we will have a good view of, yes, this is the standard that the medical colleges are maintaining. So that was not totally lacking. That's why I said, where are the HODs? At least I will request them, no? Please take the initiative and give them 2 days leave to present their thesis in the competition.
Right, sir.
This we need to inculcate, or we need to spread the message across to whichever HODs are coming across. We should tell them, yes, these thesis presentations are not happening so often. Let us do something for that and encourage the students to come to the state conference and present their work. If they look back into their work, they will also have a good insight.
Right.
The students will have an insight. So personal development also will be enhanced. So that is my personal request. I know you very well, so I think you please take that as a agenda for you.
So I request all the staff members of the present Bhimshars, also they should take your personal interest.
No, it's not only Vimsar. I'm not criticizing Vimsar. It is all medical colleges. It's not Vimsar. Actually, 2 presentations, both are from Vimsar. So I appreciate that. But there are other medical colleges are also. Even 1 or 2 thesis presentations from each medical college will make handful of very good number of presentations. And once the number exceeds, then we will look for the quality. Quality presentations will be selected. Thank you for that.
Okay, sir. Thank you.
That HOD decides, okay? First of all, HOD changes, everyone changes. Top to bottom model. Or second is bottom to top model. The students are so inclined, they will ask their teachers, somehow get the material, somehow teach us, somehow give all the capabilities to us. Either way, it should function. Yesterday also, in the inauguration, it is so exciting that everything will be done like a click of the button. But while come to the practicality, nothing is happening. That's the main painful problem. Thank you for
Thank you, sir.
giving this opportunity to chair this session.
Thank you, sir.
So thank you, sir. I would like to call Ajit Babu, sir, for small mementos to all the speakers. First, I would like to call Dr. N. Debadatta, sir. Dr. Sujata Pranambada. Dr. Ajay Kumar Singh. Dr. Gunasagar Das. Dr. Gunasagar Das. Dr. Syed Ayaz Hussain, last.
First one, last.
So thank you. We'll start the next session for oculoplasty vast.
Very good afternoon, no morning. Sir, that's it? Yeah, morning. To all our delegates, the last session for this hall is the most interesting one, the oculoplasty session. We have here Dr. Pushpa Kumari as our chairperson. And today Dr. Mona Lisa was supposed to come, but she could not because of some emergency. Our first speaker for today is Dr. Surya. And we won't be following the 5 minutes rule because we have enough time for discussion and all. So it will be all spread out over 1 hour. It's anyways is the last section.
Just an announcement, actually. I think please be careful when you are loading your presentation there, because if there is a pen drive, it is wiping out everything. It's happened with 2 of us already. So if you've got a Microsoft system, then a little careful with your I'm going to talk about, very good morning to you all. I'm going to talk about frontalis flap. We all know that actually, as far as ptosis surgery is concerned, there are several techniques, and I want to just bring in frontalis flap. And to be honest, actually, while we know that most of the time I'll focus on things, let's say, when exactly are you looking at using frontalis flap? You would think about frontalis flap whenever there is a poor LPS function. And that may be congenital, that may be either because of trauma, extensive damage to the muscle, or whatever. But essentially, you're looking at where the basic tenet is going to be, it's going to be a poor LPS action. And I would consider that from a clinic measurement, anything which is 4 millimeter or less, I would think that as poor function. Now, this particular picture tends to show you in green what are actually the elevators of the eyelid. And on the left, you see the levator palpebrae superioris shown in green, which forms a part of the SR-LPS complex. And you also have frontalis muscle as you show it. And the idea of showing this picture is to focus on the green patch in the frontalis, the way the muscle is oriented, because that's what we are going to bring down as a flap. Now, this is a common example of how you would see a patient. But I want to take a look at this particular picture. Now, without doubt, there is frontalis overaction, and this child has actually bilateral ptosis. That's very important to talk to the parents about. The next thing is, if you see very minutely, I don't know, I think you have a reasonable good resolution there. You would see the right eyelid has forming a little bit of a faint crease. That tends to show it has a little better function compared to left. So the management modalities could be, you are talking about a bilateral surgery, or you could think about a unilateral surgery, depending on what the parents are agreeable to. Now, I'm pointing that out because we'll see this picture again. Now, coming back to the how the muscle is, now this particular picture actually tends to tell you that the muscle, the levator palpebral superioris is the beauty about the muscle is it actually travels horizontally and then goes to the vitrinals, and the vitrinals changes the direction down. But frontalis muscle is a vertical muscle. So if you bring it down to the eyelid, one of the things that is there is, while it doesn't need to change direction, but there is a fullness in the upper part of the eyelid which tends to stay. And that seems to have sometimes, if you are doing a unilateral surgery, to make it appear a little asymmetry, if I can say that. I want you to focus on the two bottom, actually the first one is the normal anatomy. So what are the techniques? Now in schematic, this particular article which was published beautifully represents, let's say the first, which is B on the right side. Now that's the kind which is a direct flap. You bring down the frontalis, and that's what, when the brow raises, it picks up. The second one and the third one, both are pulleys, where basically you bring the muscle, but you change the direction again by trying to change the direction of the muscle by taking it underneath either a septal pulley or you take it in the levator pulley. So basically you create a change of direction by using a pulley. Now this is the picture. I don't have any videos for this, but essentially the picture portrays. Now the first picture tends to show that I'm actually holding I use a single crease incision. With a Damar retractor, I'm lifting the skin crease, and actually I tend to hold the muscle, which is the frontalis muscle, with a multiple tooth forceps. That's something that we usually have. And dissection is carried at two planes. One plane is between the muscle and the dermis. And that's, I think, the difficult part. Because when you progress along that plane, you would see the cilia, or actually the root of the brow hair. You would notice them. And you have to keep constantly reminding yourself that you have to go underneath. Is the time over?
Yeah, I think we can turn the timer off for our session.
Well, okay. So basically it shows the flap and it brings down, and you see the contour, and what you do, you bring down the flap, you may or may not take relaxing incisions and then fix it to the tarsus. That's how the lift. And of course, where do you leave the eyelid? In frontalis flap, the best place to leave the eyelid is above the limbus, right? So that's something which is most of the times you would do this surgery under GA. This is just about, talks about, well, am I taking out fat? What kind of a flap I'm doing? I'm doing a U-shaped flap, and I avoid trying to take relaxing incisions on two sides. With, without pulley, at this beginning when I was doing this, I've been doing this surgery for about 2-3 years now. And without pulley is what I was. And of course, any patient wherever there was a levator muscle action was poor. So those are the indications for the surgery for me. Coming to this particular individual who came young, possibly, I mean, he was preparing for his engineering exams, if I remember. The important thing is the right picture actually tends to tell you that, well, he doesn't have any lag off in the beginning, but he's already undergone 2 levator surgeries earlier in 2020 and 2022. And one of them was also along with a blepharoplasty. And that's him at the time. This is what we get after the correction with frontalis flap. Now we get a little better, but the contour was not something that I was very happy about, and I had a little bit of a lag off, and this picture is about 6 weeks after the surgery. This is the same boy that I showed earlier, and for reasons that are, I would probably not keep it here, but essentially the father decided that I only want left eye surgery. We couldn't really convince that it's bilateral. So there was something, and after I have done the left eye frontalis flap, what I want you to see is take a look at the way the crease is forming, because we formed a crease forming suture, and we have also taken sutures for crease formation. You have to take it along with whatever is the retractor. If LPS is poor, you can't take it with LPS. Here frontalis is the retractor. So with the frontalis you have to take so that the crease forms. But obviously because of the surgery you have a little bit of a lag, but no clear, Bell's was good, so no issues about that. This is a guy, older gentleman with very heavy brows. Very heavy set of brows he has and brow hair. This is him before and after. So now I come to the change in technique. I changed the technique based on literature to the pulley technique. Now what do you do in this push? What you see in the picture on the left is the frontalis flap, but the marker is showing the frontalis flap. The second picture on the right is showing that I have created a pulley underneath by incising through the septum. And my Westcott scissor is going underneath it to show that I have created a tunnel. And then the third picture is showing that the frontalis flap is coming underneath that particular pulley that I create. So I create an opening under which it comes. And of course, the last part is I'm fixing it to the tarsus muscle. The baby that you see on the right side is before and after. I'll run through a few pictures. This particular child before, and you see on the right after surgery. What is interesting is also it's something called a pop sound is talked about. A pop sound is when you lift the eyelid. Sometimes when you're doing eyelid surgery, you will see when it comes out of apposition from the globe, there will be a pop sound. So that happens because when people look up, they pull it so much that it plops out, and the apposition between the globe and the eyelid goes away. That's a complication of frontalis flap. So I'm knowingly asking the child to look up whether it is seeing that it is actually lifting up or not. But it is well opposed, because if you have that, you tend to have tear surface abnormalities. This is the same child I talked about. The first picture is before. The second picture is actually after silicone rod that I did. But you see a small lesion, a small granulation which is there on the brow, and that's why I had to revise it. I took out silicone rod and I did frontalis flap. This is a child which I did frontalis flap with a pulley technique, and the crease forms much better. Right? You see a little bit of a change in the way the lateral canthus angle is, but that's there on both sides. You see there's a little difference in the way the eyelid orientation in this child is. This one was when we did it for the left, a little undercorrected, but that's the best we got. Finally, I want to show a few where, well, on the left one, the first picture is a different patient and the bottom one is another. Again, undercorrected. But the point is, if the other eye is also a little low, I tend to tell people that I will try to bring it sort of symmetrize the asymmetry is something that I try to talk to patients. No surgeries without complications. So you see undercorrection, you see the eyelid crease not looking the same, and also contour abnormality, with probably the first picture would need a little more of a skin muscle excision so that the tarsal platform show looks very same. So in a sense, helpful surgery, nothing new about this, has been there for a very long time, but has been more in discussion recent times. I think apart from the results that I show, one of the big advantages is it is autogenous tissue, same incision, you don't have to go for a fascia to a second incision. Generally, I would do it under general anesthesia, and the best advantage is probably because you're using muscle, the lag is very minimal compared to at least fascia. Thank you.
Thanks a lot, sir. Any questions from the audience?
Yes.
Yeah.
So, yeah, that's a good question. So essentially, sir wants to, sort of opinion is what exactly is the role of superior rectus in this, in let's say the decision or planning of ptosis surgery. I would put it this way. So if you're dealing with, obviously you're dealing with a ptosis, that means there is a weakness of the LPS muscle. But if you're dealing with a weakness of the superior rectus, what it tells you is that number one, rule out a vertical strabismus. Because you may be dealing with a monocular elevation deficit. And you know the moment the eye which you are saying is ptosis, you should always ask that patient to look in that eye. That eye should be fixating. So the reason I bring in this vertical strabismus will change the level of correction. So you need to exclude that. That's very important. But there's also another scenario where you have a superior rectus elevation deficit, but the patient has a good primary gaze. Those ones you need to always look at the bells, because those patients are likely to have a poor bells. So I think the relevance of the superior rectus is in understanding whether the eyes are aligned, and the second thing is you should also look at whether the bells is good. But superior rectus helping us as a part of ptosis surgery is only as corroborative. That means we do LPS, but if the superior rectus is good, the eyes are aligned and give us good results. I think that's what I would think is. Superior rectus used for ptosis correction is not something that I have come across, but then it's an elevator for sure, and I haven't seen anything, not exposed to something like that. Yes, yes, please.
Frontalis flap.
Pardon me? Just repeat.
Sling. Silicon rod and frontalis flap. Patient selection.
What is the question? You want to?
When you will prefer sling?
Okay, how to select? I think silicon rod is, see, it's much easier in technique, it's much easier to do, but the biggest disadvantage, the advantage with silicon rod is the lag is probably less because of the elasticity of the rod. But the disadvantage is the longevity of the surgery. 9 out of or 8 out of 10 silicon rods that I would do, depends on the technique and how you do it, but many of them, over a period of time, the eyelid would drop down and you keep on adjusting one after another. Second, it's a foreign material. So some people will have reactions. So I think any time where you have a issue about or worry about that exposure may be a risk, you may still do silicon rod. But if you want a surgery that will last, has good or very minimal lag off, and will give you results for a much longer time, you would think about opting for autogenous tissue, either fascia or frontalis flap.
Questions. First is, while forming the flap of the frontalis, have you ever faced cheese wiring?
Yeah, I think when you're holding with a multiple tooth forceps, you are giving traction, and that's there definitely. But see, frontalis is a very thick and has a significant amount of breadth of the muscle also. So if you're careful, you may have cheese wiring in 1 or 2 zones, but you will still get a good section of the muscle. Like I was showing, I was getting a broad muscle brought in underneath and then. And you have to keep always bringing it down to know where exactly you're fixing it. Because remember, if you're weakening it too much, your ptosis correction will not be good.
Weakening as in removing
So if you are basically bringing down frontalis as a flap from its regular insertion, right? You are disinserting and bring it down. If you bring it down more than is needed, then when you lift, obviously the correction is not as good.
And you have never tried making it 2 flaps and...
No. No.
And sir, when you talk about the pulley, do you need to attach it backwards towards the LPS?
No. You just have to bring it underneath the pulley.
That
It's like
itself-
it's called a pulley because it changes direction. That's all.
That's all. Okay. Thank you so much, sir.
So tensor fascia lata is a known technique. That's what I have been referring to as fascia lata. The difference is essentially you're going to the second site. I do quite a bit of fascia surgery for correcting ptosis, but my selection now, both are autogenous tissue. Number one is I'm going to a second site for fascia, for tensor fascia lata. Number two is lag is more than frontalis flap.
We now have Dr. Devjyoti Tripathi, who's going to speak about endoscopic DCRs.
So, a very good morning again. Yeah, better to move around. So, I probably have a couple of videos that will take up a little time. So, this was essentially for beginners. So, this is a surgery that I think all of us are pretty familiar with, and many of us do. And interestingly, apart from routine cataract surgery, there are very few surgeries in ophthalmology for which you can claim a 95% plus success rate confidently. This is one of them, if done right. So this is something that we ophthalmologists have ventured into an area of anatomy that is not our own to start with, not the primary place that we usually work or are used to. So it is essential that we learn a little bit of the area where we work for this particular surgery. So what we are used to is generally this. We are used to being taught this anatomy when we are in our residencies as well as in our fellowships in oculoplasty. And the approach that we are taught in external DCR is something that goes this way. When we change over to the endoscopic technique, we need to approach the same area from the other side of the fence. So the approach essentially changes to that way. Now, when we are in the nose, and this is the change in approach that we are face to face with, we need to understand the anatomical structures that we are working with. So as you can see, if you go down the path of the red arrow, you're going to encounter different structures. If you go up the path of the blue arrow, you're obviously going to encounter different structures. So we'll start with the bones, and we will just put layers of tissue on the bones one by one and see what we come across when we deal with an endoscopic DCR in terms of basic anatomy. So these are the bones. What we are interested here primarily are the lacrimal bone, the inferior turbinate, and the maxilla, which is M, IT, and LS. Sorry, LB. And where we start our osteotomy when we do an endoscopic DCR is that area, which is the lacrimo-maxillary junction, which is essentially that red line. Now, when we do an endoscopic DCR, we start our osteotomy there and we progress posteriorly, and we remove the lacrimal bone progressively. As much of the lacrimal bone is removed, we come across the sac, and we may need to remove a little bit of the frontal process of the maxilla also, which is anterior to that red line that we have drawn in the middle of the blue oval. Now, so that's again the orientation of the sac. That's the middle turbinate there, and that's how the sac is located. So there are two important things here. The direction of the blue arrow, because that is the view that you see with your endoscope, and the fact that you need to understand very well that the fundus of the sac projects a little bit superior to that blue arrow. That is the most important thing, because the internal common opening lies within the fundus of the sac. And if that opening is not unobstructed, not free, no matter what else you do inside the nose is going to end up in failure. Right? Okay. So another view, this is a skull view. So this is what shows you the fence as I speak of it in between, with the lacrimal sac on one side and the nose on the other side. You see the middle turbinate there, and what you see circled in yellow is the agar nasai. Now that is again a very, very important landmark, because that lies just next to the axilla of the middle turbinate. The axilla is essentially the root with which the middle turbinate hangs to the lateral nasal wall. Now the important thing is that we need to note the relationship of these structures on either side of the bone in the middle, because that is the bone that we need to remove to progress from within the nose to the lacrimal sac. Again, that is the path that we take. Right. So, more details of the anatomy. That structure there we see labeled with the arrow as ML is called the maxillary line. This is the most important endonasal landmark for endoscopic surgery, because this line represents the lacrimo-maxillary junction of the bone that we saw a few slides earlier, where we start our osteotomy. How we identify the maxillary line, we are going to subsequently see when the soft tissue layers come on over the bone. So there you have the soft tissue layer over the bone. So the labels are self-explanatory. AN is the agar nasai, AX is the axilla, MT is the middle turbinate. And you see that ridge that goes from the axilla right down till the inferior turbinate at the bottom. That is your maxillary line. And the dip behind the maxillary line is where your middle meatus starts. Now when you superimpose the sac on this particular picture, you can see that the fundus of the sac lies significantly above the axilla of the middle turbinate. And this is very important, because your incision should extend to a point where the fundus of the sac is appropriately exposed. We are going to see that subsequently, how that is to be done. Right. So now we put the soft tissue back. Now we have taken some of it off. So there is the maxillary line with the small black arrows, and then you have the lacrimal bone exposed. So that is the bone we are going to remove when we actually perform the osteotomy. That is going to be our lacrimal drainage passage, which is to be created new. So further removal of soft tissue, you can see the other details now. And what you see again here is the uncinate process, which is labeled as UP there. And that is something that we usually come across the posterior part of the sac when it is exposed. When the sac is being exposed, you sometimes come across the uncinate process, which covers the posterior part of the sac. Sometimes we need to do an uncinectomy so that the sac can be properly exposed. And this presence of the uncinate process and the location can vary with race. Okay, I'll just skip these. We all know this, the pre-op assessment, what we do before we take a patient up for surgery. This is something that I would recommend all beginners to do. This is the standard ENT teaching for examining the nose with an endoscope. This is essentially an examination of all parts of the nose pre-operatively, so that you know what you're going to deal with and you don't end up with a surprise on the operating table. As far as this particular surgery is concerned, it is the second pass, which is the most important part to be done in meticulous detail. Okay, we come back to the essential picture that we are going to refer to time and again. So we saw these, and now we are going to see how the steps of surgery can be superimposed on this anatomy, so that you do the steps in the right manner, you identify the right structures, you reach the right place, and you perform the appropriately meticulous surgery. Okay, so that is step one. So first, we design a flap. You see the line diagram on the right of the screen. So the middle turbinate is there, the axilla is there. We measure roughly 10 millimeters superior to the axilla. 10 millimeters away from the axilla, that's the arrow marked towards the left, and inferiorly, the vertical limb of the incision is roughly 2/3 of the length of the middle turbinate. On the left side, you can see an endoscopic view of an actual patient where the flap has been marked. It's the blue stippled area that is the flap. So the red arrows show you the superior border, the yellow arrows show you the anterior border, and the green arrows show you the inferior border. Now when this rectangular flap is incised, it is elevated off the lateral nasal wall, it comes off as a hinge and is reflected towards the middle turbinate, thereby exposing the bone, which would be, in this particular picture, towards the left of the flap. Okay, so this is the marking of the flap. Then what happens? We elevate the flap. So when the flap is elevated, then what you see underneath is actually the bone, and usually it is the frontal process of the maxilla. Now the picture which is on the left actually shows a patient which has the contralateral side compared to what is shown in the line diagram. So the line diagram shows one side, the picture actually shows the other side of the surgery. But what you see here is essentially the frontal process of the maxilla, which is this bone. And what you see here is the beginning of the osteotomy. Now when you begin the osteotomy here at the bottom, what you initially expose is the bony nasolacrimal duct part. This is the flap which we have raised from the lateral wall, which is this. This is the middle turbinate here. You're seeing the inferior part of the middle turbinate. The axilla is somewhere here. And slowly, as you go up, removing the bone bit by bit, what you expose is the entire length of the sac. The fundus of the sac is somewhere here. So we are going to see this subsequently. So now you can see that much of the bone is gone. This is the inferior edge of the osteotomy. This is the anterior edge of the osteotomy. This is the superior edge of the osteotomy. The nasal mucosal flap remains here, and this is the sac. You can see the entire surface vasculature of the sac clearly. So our attempt is to have a wide marsupialization of the sac into the nasal cavity to form a good osteotomy. And to do that, we need a very good exposure of the sac from top to bottom. So that is essentially what we intend to do. Subsequently, we open the sac. So what you see here is the creation of the sac incision. So the blade is inside the sac. The tip of the blade is inside the sac, and the incision has started here, and it is in the process of getting done. What you also see is this, the tenting of the probe. You can see the tip of the probe here, and you can very faintly see the probe here. So this tenting holds the sac tight, and you can actually penetrate it because it is swollen. And there is enough space inside for the blade to go in and make this cut. So we start here, and up we go. And then we end up making two flaps, just in the manner we make in external DCR. So you see the probe here coming out of the internal common opening. This is the posterior sac flap, and this is the anterior sac flap. Now what do we do with this flap, and what do we do with this flap? That is what is to be seen next. So the posterior flap is reflected posteriorly, and it is anastomosed with the nasal mucosal flap. This is the nasal mucosal flap that we raised from the lateral wall. And you can see the line of anastomosis here. So this is what is required to get good primary intention healing. If you get this done well, you will usually not encounter granuloma formations, and you will have a very good mucosal healing of the osteum. The anterior flap is reflected back anteriorly towards the bony osteotomy edge, which is here. And right in the middle of it, in this place, this is not seen properly because it is a 0-degree endoscope picture. The internal common opening is located here a little further inside. And what you see here is actually the inner mucosal surface of the sac. The sac is completely opened up. So this kind of marsupialization is something that we intend to do, and this is one of the most critical steps to have good surgical outcomes. And then finally, we have bicanalicular intubation. So you can see the tubes coming out through the internal common opening. You can see the anterior flap here reflected over the bone. You can see the nasal flap here in position and well opposed with the posterior sac flap along this line. So that essentially completes the surgery. Let's have a look at the video as we go step by step. So that's the axilla. That's the middle turbinate. This is the place we are going to work in. This is the maxillary line. It starts here, it comes down. That is the uncinate process. That is the bulla ethmoidalis. We are concerned with this area, here. So as we talked of, we see the marking of the incision. So that's the horizontal part. We come down with the vertical limb. This is the same patient that was shown as a still picture. The same flap, the one that we saw in the still picture. And that's the horizontal limb. Okay, so there are many variations in technique. There are many different instruments that you can use to make this flap. Initially, as a beginner surgeon, I used to use a 15-number blade. Today, I use a crescent. I use a crescent only to make this vertical cut. I don't make the horizontal cuts at all. I make this vertical cut, I lift the flap, and then I use scissors to make the horizontal cuts, and I make them in a direction that I want to make them so that I can manage the exposure as well as the size of my flap. So that's just something that I have learned with exposure and with experienced tissue handling. So there it goes, lifted away from the lateral nasal wall. And right, so this is, I would do this for the upper horizontal incision now. So you come across the lacrimal bone, which is what we know as lamina papyracea. It's paper thin bone and you can take it off. But here, this is the uncinate process. We saw a prominent uncinate process in this particular patient, if you remember at the beginning. So in this case, it appeared to be obstructing the exposure of the sac. So there is an uncinectomy which has been done here. Then we start off with the osteotomy at the bottom. So what I am actually removing is the bone at the lacrimo-maxillary junction. So each grip of this bone is partly lacrimal bone on the posterior side and partly the frontal process of the maxilla on the anterior side. We progress superiorly, and here is what becomes a little difficult. Now we have mechanized instruments which we can use to actually, you can see the sac being exposed. This is a 30-degree endoscopic view, which shows you a much closer view of the superior bone that we are trying to remove. We do have mechanized instruments like bone burrs, which we can use for the removal of this part of the bone, but in this particular surgery, I haven't. So you can see how the sac is exposed right from the top down to the bottom. That is what we intend to do. So that kind of exposure, complete exposure, gives you a good marsupialization when you open it up. So I use a keratome to open the sac. This is a long bladed keratome. It's easy because the blade is curved and it's very long, helps me manipulate it within the nose. there is our nasal mucosal flap that we have elevated away from the lateral wall. And that is going to form the, so there you can see, I'm sorry, I think this is not, there you can see, so my scissors is actually pressing and reflecting the posterior sac flap. And my keratome here is actually reflecting the anterior sac flap anteriorly. You can see the apposition, which will be along that line. Okay, now you see, this is the nasal mucosal flap, which is now in apposition with the posterior sac flap. Some intra-sac adhesions that are being released, and we finally go through with the intubation. Okay, so this is an intubation set which has flexible bodkins. It is a little different from the usual steel bodkins that we have. So these are flexible bodkins. And they are actually intubated through a guide. But the rest of the intubation set is medical grade silicone, as is routinely used. So, and that's a small piece of absorbable gel foam that we coat with triamcinolone, and we put it there opposed against the flap and slightly against the internal common opening. So that helps in curbing fibrosis. So that was the surgery. Now, what happens after the surgery? What else happens after the surgery? So let us have a look at this. So once when you have done the surgery, so this is the ostium as it is seen intraoperatively. You can see the internal common opening here. The tubes coming out. You can see the inside of the sac. This is at 2 weeks post-op. So you see a nicely healing ostium. You can see the drainage. The fluorescein is here. You can see the dynamicity of the internal common opening by the movement that is transmitted to the tube. And you can see some healing here. There's a little bit of a blood clot along the anterior margin. Essentially, this is as near to an ideal ostium that you can get. This is the core of the surgery. The healing that happens here is what gives you a success or a failure. This is at 1.5 months. So you can see a couple of granulomas here, small granulomas. Now granulomas can be very dangerous if there is a small granuloma here too. So these can be, so that's the ostium. This is a 0-degree view. So the ostium is actually in towards the left. You can see my assistant pressing from outside. And here you have the 30-degree view. Now you can see the assistant pressing from outside. And you will see the fluorescein coming out. So that slit that you see here, that slit there, that slit. So that's the internal common opening through which you can see the fluorescein draining out. Now these granulomas, they form at places where we do not have mucosa to mucosa apposition and secondary intention healing has occurred. So these granulomas which are at the borders of the ostium are usually non-threatening. We can just let them be. But if these happen somewhere in the middle of the ostium, which we call as bang-on granulomas, then they can lead to failure. 3 months. So more fibrosis, but complete healing of the ostium. Now there is a granuloma here, very small one along the anterior border of the ostium. We are not bothered about it. We'll just let it be. You can see the internal common opening moving. You see the fluorescein coming in. So that tells you that the drainage is appropriate, adequate. And then at 7 months, further fibrosis, the granuloma is settled down a little more, but it's still not gone away. But everything else seems much quieter and more healed, tissue more settled, much flatter. And then you see the 30-degree view, and you can see the internal common opening up there, and you can see the fluorescein flowing in. You can actually see the tears also, even without the fluorescein. So that's what happens after the surgery. Thank you.
What about the here they are not mentioned about the flap suturing. Suturing of the flaps are not required? Or
We don't suture the flaps. In this, we don't suture the flaps. There was a time when I used to use fibrin glue. With the flap apposition, I would apply fibrin glue at the junction. But now I don't apply fibrin glue at all. You just let the flap oppose to each other, leave it for some time. The natural fibrin takes care of it. It stays. Yes, absolutely.
patency continue. Patency.
Which opening is small?
This teething. If you are teething this silicon teething, you are doing or only?
Pardon?
Silicon TV you are using or what?
Just a sec. Pardon me. Sir?
Silicon tubing.
Routinely we use in all surgeries.
Okay.
Silicon tubes. Yes, please. There is an apposition.
Only there is a close association and no glue is applied. So
No, that is the apposition. That works. You saw the healing.
yes, but when the opening is very small, chance of failure is more as compared to
Which opening is small?
inner opening. When you oppose it to
The ostium has the entire ostium is the big cup-like thing that you saw. The depression.
the bony opening is quite good, but the mucosal opening is left as such.
Mucosal opening, the size of the mucosal opening,
Bony opening is good. Bony opening is good, but the mucosal opening only cut the mucosa and left as such, without any cutting. Yes.
I don't exactly understand. We cut the mucosa, but okay. You want to say something?
See, I think so the point you are making is correct because you're looking at the mucosal opening of the edges of the mucosal ostium. And there is a bony ostium. The point is that all mucosal opening, whatever or however large you may make, will contract with time. That's a known thing. It's a known study, right? So the question is whether a small opening is functional or non-functional is a completely different aspect. So that is the reason why outcomes of DCR are based on functional outcomes, which is essentially whether you do fluorescein endoscopic dye test or fluorescein dye disappearance test, whichever way of functional part you want to look at. So I think the key thing is he very clearly showed that there was an apposition between two mucosae. If you bring two mucosae into apposition, whether you put sutures or not, epithelium will grow over it. That's the concept. And that is why we tend to see very good outcomes because you essentially leave two mucosae absolutely attached to each other. Whether you use anything else, you keep it like that, it stays pretty much. The posterior anterior both he showed.
Essentially, if it's the size that you are particularly alluding to, whenever you make a bony opening, it has been measured that for any given bony opening, if you make a soft tissue opening within that bony opening, the size of the soft tissue opening is roughly 60 to 65% of the size of the bony opening. Right? That's the ratio. So that is one of the reasons, the basis for us teaching that you make a big bony opening. The bigger the bony opening you make, the relatively bigger the soft tissue opening becomes. But if you follow the margin of the bony opening, in making your soft tissue opening, the best you are going to get is 65% of the size of the bony opening. And remember that in the post-operative period, the bone doesn't get edematous as much as the mucosa does, right? So the mucosal opening is going to contract. But then with healing, as the edema resolves, it again becomes larger as fibrosis sets in. So it's that balance, and we really don't have much control over that balance. What we can do is play with the size and the apposition. That the ab gel, the gel, no, we just let it be. But over time, I have stopped doing that. I don't give it because I saw, that's a good question, because I saw with time that it hangs inside the nose. And it stays for a very long time. It doesn't disintegrate because there is no tissue milieu or tissue microenvironment which is acting on it. It is just hanging free inside the cavity. So I stopped doing it. Now what I do is I actually directly inject triamcinolone along the border of the anterior osteotomy into the lateral nasal mucosa. That works just as well. Yes, yes. Theoretically it can be used.
So granulation tissue, you address recurrent granulation tissue?
Granulation tissue, you have multiple ways of addressing. You can inject, yes, you can give nasal sprays. Depending on the location, you can just let them be and see how they behave. Many times they shrink in size. They may not go away completely, but they will shrink. They will become sort of dehydrated, if I can say so. But if you think that it is going to be risky or it is going to influence the outcome or there is a potential progress towards failure, you can always inject triamcinolone into the granulation tissue. And then there are other ways of, silver nitrate and things like that.
Thank you, sir.
Thank you so much, sir, for a very nice talk on endoscopy. Now we have Dr. Madhusmita from Kolkata for her talk on the lateral tarsal strip.
Good afternoon, everyone. Thank you, organizing committee, for this opportunity. Today I will talk about lateral tarsal strip. It's a very easy but most useful surgical technique that we encounter routinely. About its principle, here the lateral canthal sling, it shortens the lead and raises the lateral canthus. And the lower limb of the lateral canthal tendon is cut and a new lateral canthal tendon is created. And about its indication, it is indicated where there is lateral canthal tendon laxity and generalized horizontal lead laxity. What are the steps? First, we need to do lateral canthotomy. This is done by giving one horizontal cut. Then inferior cantholysis is done. After that, a strip of tarsus is formed, and the strip of tarsus is being shortened, and the shortened strip is being reattached to the periosteum on the inner aspect of the lateral orbital rim. Then any redundant anterior lamina is being trimmed off and the canthotomy is closed. Before the surgery, we need to give anesthesia on the periosteal rim, to the inferior fornix, to the lower lid, lateral lower lid skin. And about the surgery, it's not clear. As I said, we need to do canthotomy. For canthotomy, we have to give horizontal cut on the lateral canthus. After canthotomy, we need to do inferior cantholysis. After inferior cantholysis, we need to give incision at the junction of anterior and posterior lamella for about 5 millimeter to separate the tarsus. We need to do the dissection with the help of scissors for about 5 millimeter. After that, the skin is being excised from the tarsus. Skin should be excised from the tarsus. Then you need to denude of conjunctiva from the posterior surface of the tarsus. That can be done with the help of a 15 number blade or with the help of cautery. Then after that, we have to shorten the tarsus depending on the amount of lead laxity. Once the tarsus is shortened, we need to suture the tarsus by taking bites from the anterior and posterior surface of the tarsus, and the bites should be taken from the periosteum on the inner aspect of lateral orbital rim. First bite is being taken from the periosteum on the inner aspect of lateral orbital rim. It should be inner aspect of lateral orbital rim. The first bite is being taken, then we need to take another bite. Then the second bite is being taken from the periosteum from the inner aspect of lateral orbital rim. And after that, we need to tighten suture. We have to maintain moderate tightness. It should not be very tight. And after that, as I said, we need to cut off or trim off anterior lamella. Then we need to close canthotomy. It's a very simple but most useful surgical technique. Then about pentagon wedge resection, though it's an alternative but less appropriate way to tighten a lower lid. Where we excise pentagon wedge of eyelid, it's usually done at the junction of lateral 1/3 and medial 2/3 of the eyelid. But what are the advantages of LTS over pentagon wedge resection? We need to remember the pathologic problem is at the lateral canthus. In older patients, the lateral canthus is often blunted or rounded as a result of stretching of lateral canthal tendon. When we do LTS, it recreates the inner lateral canthus and pulls the lid laterally into the natural position. And lateral strip sharpens the lateral canthal angle, whereas pentagon wedge resection does the opposite. It shortens the palpebral aperture and blunts the lateral canthal angle more. And pentagon wedge resection, it requires precise alignment and reconstruction of lid margins, whereas LTS operation requires no lid margin sutures and somewhat simpler. Thank you.
Thank you, ma'am. Any questions? Any questions from the audience?
A very good video actually to tend to show, and I absolutely agree that lateral tarsal strip is the most useful procedure in plasty. There's no doubt about that. Just a very quick one is that when you do the surgery, you very nicely also pointed out several times that it has to be the inside surface. So you have the bony rim. So it's very, very important to make sure that you actually, because you can't see, it's essentially a blind technique. And you want to hit the inside of the bone and then come out. That's very important. But to be able to do that, if I can give a small practical tip, I personally feel that if you have a little longer needle, and the times that I feel is I almost always do it with a 5/0 vicryl, not a 6/0 vicryl. Yeah, so whatever is bigger, because the needle is bigger, and it has to also have a sharp edge, some sort of an edge, which will be, the needle should not be a round body needle or something. It becomes very difficult. So it's got a cutting edge. And then, so once you have done that, how you take that suture doesn't matter. You have tried to probably take it both on two sides. That means you're taking anterior to posterior and then tying it. That's fine. But the other thing is, post-surgery, you ask the patient to, because the patient is under local, so you ask the patient to look sidewards. That means there is a abduction. And try to see whether there is still any apposition. How well is the globe apposed to the eyelid? Because generally when you see, if you somehow you have managed to not take the inside, then there will be a little bit of a standoff. And that tells you whether your suture is in the right place. So that's a very fine tip. You would do it in vicryl, which is an absorbable suture, but it takes about 3 to 4 weeks to scar, and that gives the end result pretty good. Non-absorbable suture is also fine, tends to stay for a longer time, but I think with absorbable sutures also I have never faced a problem, unless the only thing the post-op is, I ask patient when you are wiping, don't try to pull this from lateral to medial. Sometimes when you have taken it very delicately, there is a chance, but otherwise I think it's very forgiving surgery, very good results.
Thank you so much, ma'am, for the very nice video. Now, Dr. Sandeep from AIMS will be presenting his talk on OSSN involving the limbus.
Okay, it's already past 12, so good afternoon you all.
12:30, sir. Sorry,
So, my presentation is on management of ocular surface squamous neoplasia involving limbus. What is that? Ocular surface squamous neoplasia is an umbrella term which include a broad spectrum of conjunctival malignancies ranging from mild epithelial dysplasia to invasive squamous neoplasia. So I also put some factors, interesting risk factors are there. The primary risk factor, as you all know, UV rays, B radiations. But the interesting thing is that I got who spent 50% of the outdoor during the first 6. That is good. So the primary risk factors. So that is an interesting thing I got it. Who spent 50% of time outdoor during the first 6 years of the life, they are more riskier for means to develop OSSN. Also, this as in terrorism, here also the 30 degree of equator, those are residings, they also can develop this OSSN. And modifiable risk factors, you all know, gender male, age 4th and 5th decades, and race mainly African peoples. But in African, there is no gender bias. All the male and female, because both are working in UV rays, so there is no gender bias. And modifiable risk factors is all in cigarette smoking, vitamin A deficiency, chronic trauma and inflammations, and exposure to petroleum product. But few also journals, they also citing nowadays that there is a use of topical voriconazole also a risk factor for developing OSSN. Okay. And infectious disease like HIV infection 1 and 2, and also papilloma virus and hepatitis B and C. Now come to the management. Now diagnosis, as you all know, this gold standard is HPE. But nowadays in the recent decades, few non-invasive methods are also developed, but still now also gold standard is histopathologies. So non-invasive impressive cytology used to identify superficial dysplastic lesions, but they cannot be assessed potential invasive growth. In vivo confocal microscopy, they can feature out this pleomorphic epithelial cell, hyperreflectivity of epithelium, demarcations line between normal and neoplastic area, but this need a high grade of specialization in that. Means it depends upon who is doing this, how the experience they have. And HROCT allows for the detection of the treatment response and subclinical recurrence, but impossibility to perceive the deep invasion of the tumor or the histological grades. And regional and systemic investigation by ultrasound, CT, MRI are the often necessary to correct the stagings and plan for appropriate management treatment. This is the preview. This is the patient is a farmer, comes to us. Before that, there is a 2 recurrence with only resection been done, in excision been done. And when it comes to us, it's already a invasive squamous neoplasia, which is the commonest cause conjunctival tumors lead to exenterations. So it is another patient, a businessman, 1 year, but when it's come, it's in a early stage in limbal OSSN and 20 days of history. On examination, elevated grayish fleshy gelatinous sessile mass measuring 3 to 3.5 with touches feeder vessels and radially with mild congestion. So, as it is a unilateral elderly male, grayish white mass near the limbus, fleshy, sessile, feeder vessels. So, provisional diagnosis is OSSN. So, with investigations, we got in MRI minimal asymmetric enhancement in the right lateral conjunctival region, and on ASOCT there is thickened hyperreflectivity epithelium with an abrupt transition between normal and abnormal epithelium. So, as you all know, AJCC classifications, in that classification I will not elaborate all this classification, but on this classification, in this case, is a carcinoma in situ stage according to the American Joint Classification of Cancer. So again, there is a classification, clinical classification, in that according to the clinical stage, different management been done. Like if it is less than 3 kcal, then only excision. In between 3 and 6, you can go for excision with immunochemotherapy and reductions. And if it is more than that, you have to go for reduction, then excision. And if there is a scleral or any infiltration is there, then you should have a sclerectomy or keratectomy should be done along with cryo and excisions. And if then invasive, then enucleation and exenteration. So in this case, it is a grade 2 lesion where the lesion excision and cryotherapy of the margin were planned along with adjuvant therapy. So I'll show you the surgical management. So first we do there is a 4 mm normal tissue in excise, conjunctival tissue in excise. Then after doing this cautery, then we separate slowly and gently. Then with 2 mm clear corneal tissue is epitheliokeratolysis been done with absolute alcohol. Then with no touch technique, we separate the tumor tissues from the underlying tissues. We got some type of adherent, little bit adherent is there. So we plan along with cryotherapy, we do also MMC, we expose MMC at the limbal site. Then after that with after this MMC, we go for 2-stage freeze thaw technique of cryotherapy being done in the normal this normal conjunctival tissue. Then as it is in the as it is a in situ, we do a autosomal conjunctival graft. But if it is less than 4 clock hour, then we should go for a amniotic graft. It is more than 4 clock hour, then there may be a deficiency of limbal stem cells. So you should go for a conjunctival autograft from the same or from the other eye, if it is a grade is more. So, or if it is then high, or you are not able to got any auto conjunctival graft, then an ex vivo conjunctival stem cell can be done if there is a facility is there. So after that, histopathology is must. In our case, we got a hyperplasia of the epithelium, compare the thickness of the normal appearing and with hyperplastic area is in the arrow marked. And also there is or disorganized of the cellular arrangement in the nuclear enlargement and hyperchromasia in the superficial layer, indicative of low grade hyperdysplasia, and increase nuclei and cytoplasmic ratio there. So this is a case of squamous hyperplasia with mild dysplasia. Then after that, as in intraoperative, we found there is some adherent to the limbal cells there, along with in this stage 2 also you always go for a adjuvant therapy, and we have a basket mitomycin C, interferon alpha 2B, and 5-fluorouracil. But interferon alpha 2B is no doubt is the best choice, but the availability and costs is a little bit tilted us towards with the little bit side effect like stenosis, dry eye, epitheliotoxic in mitomycin C and 5-fluorouracils. So the doses of mitomycin C is QID 4 days a week for such cycle, and in interferon alpha 2B, there will QID till resolution and at least 1 to 3 more months after resolution. And 5-fluorouracil QID for 1 week followed by 3 weeks of, this is a single cycle, and this type of such cycle, there are 4 cycles should be exposed, means it should be given for treatment. And follow-up, first week follow-up, then after that monthly follow-up for 3 months, then 3 monthly for 6 months, then 6 monthly for 1 year, then yearly throughout the life. But nota bene is that any intraocular procedure like cataract surgery must be done after being tumor free for at least 1 year. So takeaway points are, OSS prognosis is good, local recurrence rate usually 5%, but all the recurrence usually been first 6 months of the recurrence. Later on the recurrence rate will be decreased down. So will be, if the first 6 months there is no recurrence, you are a little bit happy that the recurrence rate may be, chances of recurrence may be less. And meticulous clinical examination and protocol based management are a key for the management. Surgical excision with no touch technique is the standard of care, and the gold standard for the diagnosis is histopathological examination. And these are reference. Thank you. Thank you all.
Hello.
Just a quick one before she loads the presentation is that I just wanted to ask the histopathology. So the histopathology, I mean the picture, the way the video and the marking and all was very beautifully seen on the microscope, the video. Just the histopathology that you talked about essentially came out as mild dysplasia. And so whether you give adjuvant therapy, when you are giving topical drops, you are giving it as adjuvant therapy, okay? Whatever you may give. So that it's a good idea to base it entirely on your margin. There are two ways you can do margin. When you cut out the tissue, either you may ask for histopathological margins. That means the pathologist will take a look where the lesion is and how much of free normal tissue you have. And what is the base? These two things should decide adjuvant. Yeah, exactly like you send it for, and this is of course a fixed section report. But the point is adjuvant, yes or no, should depend upon the margin. So you didn't talk about the margin. You should ask your pathologist to give the margin. And based on that, adjuvant. And this was positive? So if the margin is negative, the big question is, do you need adjuvant? You may not need also, because it's mild dysplasia. It's, yeah. Yeah, but then you remember, when you are giving MMC, it will cause a significant epitheliotoxicity. So, yeah.
Now the last presentation for the session will be on Botox, the therapeutic uses, what you should do and what you shouldn't.
Botulinum neurotoxin is produced by the bacteria Clostridium botulinum. It can be lethal to human beings in doses less than 1 microgram. However, out of the 7 serotypes, type A and B have been isolated and heavily diluted for therapeutic use in the range of nanograms. None of the other 5 serotypes have long enough period of action to qualify for therapeutic use. The botulinum neurotoxin A, or BONTAs in short, are of 3 types. Onabonta, marketed as Botox, Abobonta, marketed as Dysport, and Incobonta, marketed as Xeomin. Xeomin has been found to have the highest specific neurotoxin activity and hence potency than the other 3. Botox has the least potency. All Bontas have a core of 150 kilodalton protein and a large surrounding protein of 500 to 900 kilodalton, which makes it impermeable to skin. And hence, this rules out the possibility of it ever being useful as a topical cream or lotion. The stabilization of the neurotoxin is done using serum albumin peptide, so people with known history of allergy to eggs should avoid Botox. This protein also destabilizes in 3 to 4 months, because of which Bontas work in the human body only for 3 to 4 months, after which they need to be administered again. When the signal comes from the brain to the concerned nerve, the neurotransmitter vesicles containing acetylcholine is released at the end of the nerve cell. These vesicles attach to the nerve membrane via SNAR proteins, and acetylcholine is released at the neuromuscular junction, leading to muscle contraction. When Bonta is injected into the treatment area, the toxin enters the nerve cell and splits the special SNAR protein along the nerve membrane, which would have otherwise helped attach the acetylcholine vesicle. And so acetylcholine is not released into the neuromuscular junction and muscle contraction does not happen. Sometimes in some people, antibodies can develop against the denatured or inactive botulinum antigen, and resistance can develop to that particular brand of botulinum toxin. We prepare our Botox bottle by cleaning the rubber stopper with 40% alcohol wipes. We take 1 or 2 ml of 0.9% preserved or preservative-free normal saline according to the concentration one wants to achieve. Here I am taking 1 ml of unpreserved normal saline to dilute my 50 international units Botox bottle, because the concentration that I want to achieve is 5 international units per 0.1 ml of normal saline. Before opening the vial, it should be stored in the fridge at 2 to 8 degrees Celsius. The upper shelf of the refrigerator should be fine. A reconstituted bottle can be stored at 2 to 8 degrees Celsius for up to 1 month. A cold chain maintenance during transit is not necessary for Botox. It can survive well for 7 days at 30 degrees or 14 days at 25 degrees too. Distilled water should never be used to reconstitute botulinum toxin because its pH is not the same as cellular fluid and causes intense pain upon injection. Botox is the treatment of choice in conditions like blepharospasm, hemifacial spasm, or in complete blockage or atrophy of lacrimal drainage system, etc. Here I am demonstrating how Botox is given in a bilateral blepharospasm patient who has been receiving regular Botox since the last 1 year. We clean the skin with normal saline and apply prilocaine thoroughly and leave it to be absorbed in. Ice pack is applied for at least 5 minutes prior to injection. So our target areas will be 5 international units to the depressor supercilii, 5 international units to the orbicularis 1 centimeter away from the lateral canthi but within the orbital rim, and 5 international units each in the center of the upper and the lower pretarsal orbicularis. On the left side, there is not much of contraction in the brow area, so I won't give any Botox there. Instead, I will give 5 international units of Botox to the upper and lower pretarsal orbicularis and 2.5 international units to the lateral orbicularis muscle. The patient is asked not to scrub or rub her face for the next 3 to 6 hours. Here is a patient of hemifacial spasm, having spasms in orbicularis, the procerus corrugator supercilii muscle complex, the zygomaticus, the depressor angulus oris, and the mentalis. 2.5 international units was given at each site. Always remember to rule out organic causes like aneurysms or intracranial space-occupying lesions which might be compressing the 7th nerve to give sudden onset blepharospasm and hemifacial spasm in individuals. Here is a case of complete blockage of bicanalicular systems where the lacrimal gland is being injected with 5 international units of Botox under direct visualization. Remember, regular shots of Botox injections can lead to subsequent atrophy of the palpable portion of the lacrimal gland. This is a case of acute spastic entropion in the elderly post-cataract surgery. Just 2.5 international units of Botox to the pretarsal orbicularis gave him immense relief. 10 to 15 international units of Botox when injected in the preseptal portion of orbicularis deep through the septa can result in chemically induced ptosis, as is done in exposure keratopathy cases to get a good chemical tarsorrhapy. This is also the reason why we avoid the preseptal orbicularis area for Botox injections. Alpha-adrenergic receptor agonists like brimonidine can reverse the accidental ptosis caused by Botox injections by directly stimulating Muller's muscle. This could open the eyelid by 1 to 2 mm, but the effect lasts only for 6 to 8 hours. There are other scenarios where Botox has been successfully used to provide relief to patients. Meade syndrome is a debilitating focal dystonic movement disorder characterized by blepharospasm and oromandibular dystonia. Other than severe blepharospasm, involuntary lower facial and masticatory movements like grimacing and clenching actions can be seen. Treatment is usually a combination of botulinum toxin injections, oral muscle relaxants, anti-epileptic drugs, and psychoactive drugs. Apraxia of lid opening or ALO is a rare disorder characterized by a patient's difficulty in initiating the act of lifting the upper lid despite normal oculomotor function. There is an inability of voluntary eye reopening with or without orbicularis spasms despite sustained frontalis correction. Like Meages syndrome, basal ganglia might be at fault here. Botox injections for spasm control with frontalis link or a permanent partial orbicularectomy might help these cases. In refractory filamentary keratopathy, which keeps on recurring in spite of topical steroids, lubricants, and mechanical debridement, Botox can be used to paralyze the medial orbicularis to cause functional lacrimal pump failure and create a pool of tears in the conjunctival cul-de-sac to promote corneal healing. In isolated cases of upper lid retraction and quiescent stages of thyroid eye disease, Botox can be used to induce a mild ptosis by injecting very small amounts like 1.25 to 2.5 international units from the subconjunctival side. But the results can be a bit unpredictable. Botox was first used in ophthalmology to treat horizontal strabismus way back in 1981. But currently, with the advent of various squint surgeries which can give very titrated results, the use of Botox in squint correction has fallen out of favor. It can still be used in cases where patients cannot undergo surgery.
So I want to add that while giving the Botox injection, the bevel of the needle has to be up, and the depth where depends upon the muscle that you are injecting. Orbicularis is a thin muscle. So usually the first 1/3 of the tip is sufficient enough to get in under the muscle, under the dermis, and inject at the muscle level. But if you go too deep, then you might pierce the tarsus and might damage the globe. But again, while giving the corrugator supercilii or the depressor supercilii complex, you need to go in deep. The corrugator supercilii has a deep branch as well as a superficial branch, but in therapeutic use, we usually do the superficial, not the deep much. And the processes also, it has to be given a bit in the middle plane, not too deep. So I think we'll conclude the session. Thank you all for attending. We can come for a group photo. Ma'am, group photo, please.